Hi, Professor. Shall we start now? Can you unmute yourself, please?
I'm ready anytime.
Okay, that would be great. I do believe you're having like around 200 people have been joining now in the attendance.
Okay.
So we can
Great.
start now and more people.
All right, so I'm going to go share screen.
Just, yes.
And you can see my screen.
Yes.
Great.
Can you show it up on full screen?
How's that?
If you look in the PowerPoint down, okay, you'll find notes, comments, then you will find, yes.
Yep, no, I'm on full screen now.
It's not shown as full screen. Can you just stop sharing and resharing again, please?
Okay. Okay. Can you see it? No?
Not yet. Sure.
All right, let me try sharing again. Where did you go? Can you see my screen now?
Yes, I can see the screen. If you can press for the slideshow.
Yep.
Okay, that's great.
All right. So I'll just start on my own?
Yes, I'll just to give me just 2 minutes to introduce you and
Okay.
just give the instruction for the doctors to write it down for the Q&A session, and you can start.
Perfect. Okay.
I have someone from the Design Master, so can we start now?
Please start, Dai. You can start because already we have like 300 participants already joined.
Yes, so can I start now?
Yes, definitely you can start. Please go ahead.
Okay. So dear doctors, Assalamu alaikum everyone. My name is Dai Rabia, and on behalf of our company Sanofi, I would like to thank all of you for giving us the chance to be with all of you today in the 8th Diabetes Day. So thanks a lot for your attendance. Thanks a lot for our chairman, Dr. Abnabi Attar, and our professor, Stuart Harris. Today, he will be talking to us about the multidimensional role of basal insulin in managing type 2 diabetes mellitus. Before we start, our professor is a professor in the Department of Family Medicine with cross appointments in the Departments of Epidemiology and Biostatistics and Division of Endocrinology and Metabolism in Schulish School of Medicine and Dentistry at Western University. He's also a research scientist at the Lawson Health Research Institute, who was reappointed at the third term in 2019 to the position of Diabetes Canada Chair in Diabetes Management, and he holds in the Anne McWinney Chair of Family Medicine Studies at Western University. He is the lead physician and medical director at the Primary Care Diabetes Support Program at St. Joseph Healthcare in London, Ontario, and is an integrated team-based diabetic clinic for the disenfranchised and marginalized population, which he founded in 2007. So thanks a lot, Professor Stewart, for being with us today. And for the attendees, if you're having any question during the presentation, you can write it down in the Q&A session, and it will be answered by the end of the presentation. Professor Stewart Harris, thanks again a lot again, and the floor is yours now.
Thank you so much. It's a pleasure to be here with all of you today. Salam Aleichem, and speaking to you from the other side of the planet here in London, Ontario, Canada. We're about 2 hours west of Toronto. And of course, we have this is a special year for all of us involved in diabetes, as it's the 100th year of the celebration of the discovery of insulin. And London, Ontario itself has a part in that story because, in fact, Dr. Banting, who, as you know, Banting, Best, McLeod, and Collip were the ones who received the Nobel Prize for the discovery of insulin, started his career here in London, Ontario. Professor Banting was a field surgeon during World War I, and at the end of the war, he moved to London, Ontario, Canada, and that is his house on the left-hand side. He had set up his clinic. He set up a general practice. So the first floor of the house was his clinic, and the second floor was where he lived. Now, he was not a very good general practitioner. He had a hard time attracting patients and making ends meet, so he took a job at the newly created medical school here at Western University, and he was assigned the role of giving a lecture on the physiology of glucose metabolism to the medical students. So he worked for days on this, and at the time, everyone knew that there was a hormone in the pancreas that was responsible for glucose metabolism and physiology, but nobody had been able to isolate it. And the story goes that at 1:30 in the morning in 1920, in 1920 in the fall, he had his aha moment where the night before he was giving his lecture, where he thought he could figure out how to isolate that hormone, which was later to be called insulin, and gave the lecture the next morning. Arranged to move to Toronto that next summer, so in the summer of 1921, where he carried out the experiments using dogs. And on the 12th dog, called Marjorie, he finally had pancreatectomized the dog, been able to isolate a mushy kind of solution that included insulin, and re-inject it into the dog, and the dog jumped off the table. And the rest, as we know, is history. As he went on with McLeod, he was given a first-year medical student, Charlie Best, to work with him, Professor McLeod, and the visiting biochemist Collip, who was also essential to be able to isolate insulin from that mushed up pancreas. The four of them were able to create the discovery of insulin. Of course, the rest we know is history. And in 1922, they got awarded the Nobel Prize for the discovery of insulin, and it made it available worldwide. And today, outside his house and his clinic are a museum here in London, Ontario. So that's the picture you see here, the Banting Museum. So if any of you ever get to Canada, you must come down to London and visit this wonderful museum that has all the artifacts from his original work and discoveries. These are my disclosures. I've worked with most pharma companies on strategies to improve the lives of our patients living with diabetes. And let's get into it now. So we know, and this will not be a surprise to any of you, that diabetes is an epidemic on a global scale. We have another epidemic going on right now, but in fact we know that related to COVID, diabetes is one of the biggest risk factors for poor outcomes for patients who have been hospitalized. Diabetes ranks number 2 as a predictor of poor outcome, either admission to ICU or premature mortality if you are hospitalized with COVID. But there's a lot of diabetes going on worldwide, which is why it's such a concern and a risk condition for people at risk for getting COVID. We know that approximately 9% of adults worldwide are estimated to have diabetes. And in 2017, according to the IDF, that was roughly just under 500 million people. But that's expected to increase all the way up to 629 million by 2045, which is an increase of 48% from 2017 to 2045. So this epidemic continues unabated. Hopefully, that won't be the story with COVID, but for diabetes, we can see that it will continue to rise, and it will be a continued, long-going health issue facing peoples around the world in every country across the planet. Every 8 seconds, about one person dies from diabetes. That translates to roughly 4 million deaths per year in diabetes-related complications, and it is an expensive disease, as we all know. Health expenditure on diabetes is expected to grow by 7% from 2017 to 2045, and that's going to almost be $750 billion spent on diabetes care and related complications. The worldwide challenge of glycemic control is seen here. And we know that for many years, although we've had well-established guideline targets of hemoglobin A1Cs for both type 1 and type 2, and they really haven't changed all that much in the last 20 years, where we try and get most patients to recommend a target of around 7%. You can see in this recent global view that, in fact, we're still not doing a good job. And this has been the story for the last 20 years in spite of a slew of new fantastic therapies we have. We have so many options now on how to treat both type 1 and type 2 diabetes. Of course, insulin being the cornerstone for type 1. But the technologies that have evolved around insulin pumps, etc., and continuous glucose monitoring have really made it easier to get patients to target and more safely. And the evolution, as I'll talk about in a moment, of new therapies, particularly insulin, has also made it easier to get patients to target in a more safe manner. But you can see here on the left that for type 1 diabetes worldwide, you can see that A1Cs still are quite high. This is in the western part of the world, where A1Cs are not a target. They vary between, close to 8% in most countries. And for type 2 diabetes, seen on the right, which is the majority of the diabetes that you all will be dealing with in your country, still not getting patients down to targets. In Canada, we're about 8%. This is based on a study that our team had carried out here in Canada on a couple of times over the last decade. But you can see across Europe, A1Cs of 8 to 10% almost, and in your part of the world, in the Middle East, A1C targets are really challenging, with the mean A1C across the Middle East of around 9.6%. Bottom line, there's still lots of room for improvement. So I talked about back here in 1922 with the discovery of the isolation and manufacturing of insulin for the world. The first evolution in trying to create a longer lasting insulin was the development in 1946 of NPH insulin, isophane insulin, which was really an intermediate insulin. And it's amazing that still today we're still reliant in many locales around the world with NPH insulin, an insulin that was discovered almost 80 years ago. In the 70s, we saw the evolution moving from an animal-based insulin such as beef pork to human insulin, recombinant insulin, which became the standard insulin used in all insulin products manufacturers across the world by the mid-90s. Efforts continue to try and get to develop exogenous insulin to be more physiologic. So we saw the first analog insulin for rapid acting, a fast acting, arrive in the mid-1990s. And then the first true basal insulin effort to get a basal insulin that had close to a 24-hour effect was with the arrival of glargine U100, known as Lantus, and you can see that in fact it substantially it helped eliminate much of the peak effect where hypoglycemia, particularly nocturnal hypoglycemia, occurred. And although NPH only lasted 5 to 8 hours in peak and was gone by 12 to 14 hours, glargine 100 did still have a bit of a peak effect, but approached lasting 24 hours. We also saw Detamir, Levemir insulin come shortly thereafter, so we had two first-generation basal insulin analog insulins. And then in 2012, Novo Nordisk produced insulin Degludec, known as Tresiba, and you can see that it now even further flattened the basal insulin profile and truly lasted beyond 24 hours the purple here compared to glargine 100. And of course, because of that, you see also further improvements in safety around reductions in nocturnal hypoglycemia especially. And then shortly thereafter, we saw the extended concentrated version of glargine 100 to become glargine 300, known commercially as Toujeo. And it too also now provided the world with a true once-a-day basal insulin lasting beyond 24 hours, very flat profile, very little intra-day variability and inter-day variability. So consistency from day to day, and also because less of a peak effect, less hypoglycemia. And we're going to talk more about that in our discussion today. I mentioned that many patients are still not achieving control, and it's important to try and understand why this is, even with the evolution of safer and more effective insulins. So we know that a low number of people are achieving glycemic control, ideal control, and I showed you that earlier on. But almost 86% of patients using insulins and on a background of oral agents, and 79% of patients who are using only insulins are still not at target. So like close to 90% of patients with type 2 diabetes who go on insulin are not at target. And the reasons for not achieving glycemic control for people on basal insulin with type 2 diabetes include these three factors. One, a fear of hypoglycemia, and studies have shown both in healthcare practitioners that they would treat, 3/4 would treat more aggressively if they were not concerned about the risk of hypoglycemia when it came to, prescribing insulin. And the second is the lack of experience in self-management. Pardon me. The lack of experience in initiating insulin, when the appropriate time to do, and effectively titrating insulin to getting patients down to target due to this fear of hypoglycemia. And this, of course, is what all contribute to the third point, which is inadequate insulin titration. We are still not effectively titrating insulin to the right dose to get patients down to target. And the reasons are kind of summarized on this slide. And this concept has been referred to as clinical inertia, or more recently as therapeutic inertia. And there are multiple barriers to treating intensification in uncontrolled patients with type 2 diabetes. The definition of clinical inertia is stated here. Its clinical inertia appears whenever the healthcare provider does not initiate or intensify therapy appropriately when therapeutic goals are not reached. So clinical inertia refers to clinicians and their inability to effectively get patients to target. As I mentioned, we have a wide range of anti-diabetic therapies at our disposal, but there are many barriers that exist to achieve these controls. So that, of course, and these are patient concerns and physician concerns. And the main issues for patients really focus on their fear of hypoglycemia. Yes, weight gain, we will hear commonly from patients as we intensify insulin therapy. Complexity of regimens and the multiple therapies that they're on. And there's always a concern around hypoglycemia and severe hypoglycemia around driving licenses that are being removed for patients who've had severe hypoglycemia, or if they're operating machinery. So hypoglycemia really drives a lot of the patient concerns. From the physician side of the story, effective insulin titration, again, as we mentioned earlier, related to concern around hypoglycemia, concerns around patients' adherence, which is impacted by hypoglycemia. The challenges in patients with diabetes who have multimorbidity, which is most of our patients with diabetes, to be honest. And then, of course, adverse events. And again, we're talking about hypoglycemia as a main driver behind physician concerns. So therapeutic inertia plays an important role in the delay of intensification of diabetes therapy, and substantial inertia exists at each sequential intensification step. And this is a study from my good friend and colleague Kamlesh Kunti. We've done a similar study here in Canada, where it shows that there's substantial delay even getting patients first started on an oral therapy, and it can take up to 3 years and poor control before the second oral agent is added, and another up to 7 years before adding the third oral agent, and finally up to 9 years to add insulin. And often our patients have been in poor control up until this point, and we all know that we're kind of running out of options. They're starting to develop complications. They're not a target, so we at last turn to adding insulin, which of course is a treat-to-fail approach, and as a result, we're adding it very late, already in the face of underlying diabetes-related complications. We also now, in the last few years, have had the wonderful addition to our toolbox of GLP-1 RAs, which are marvelous drugs, and recent ADA ESD guidelines recommend them as the first option, if available, for an injectable therapy. But you can also get them and use them quite effectively, as we do in our clinic on a daily basis, in combination with insulin. And that can either happen in a fixed ratio combination pen, where you have like in Soliqua, which is glargine and lexazenatide mixed in together, or in Zoltify, where you have degludec and liraglutide in a combination pen, if these are available. But you can also use GLP-1 RAs separately in combination with basal insulin. And to be honest, I think that we're seeing this combination slowly but surely effectively replacing basal bolus therapy for patients with type 2 diabetes, and also premixed insulin. So this is the future, combining GLP-1 and basal insulins. So let's talk about this issue around intensification. And the most important time to get patients to target, and the best opportunity, is when you first start a patient on basal insulin. And this has been called the insulin initiation period. And so if you have a patient who's on lifelong insulin, it's really broken down into two time frames. There's the first point in time where you initiate the basal insulin and titrate in that first 8 to 12 weeks after insulin initiation. And then the so-called maintenance period, which is defined as the period where insulin dose is kept stable. And this could be going on in the trials, of course. It doesn't last longer than 6 to 12 months. But in real life, the maintenance period is the period that we see our patients who are already on insulin in everyday time period. So the most important time to get, and the best opportunity to get patients to target, is when you first initiate and do that initial titration the first 8 to 12 weeks. And of course, hypoglycemia and the fear of hypoglycemia are the main factors that limit our ability or restrict our ability or our patients to get to the targets we want, and therefore is the reason for careful titration. Many patients fail to reach their glycemic targets after initiating insulin therapy, partly due to a lack of up-titration, as I mentioned, in their initial insulin dosing. So just to give you some background as to why this, that has reinforced why the initial insulin initiation timeframe is so important, let's look at some data that supports this. We know that that the initiation period is a predictor for long-term outcomes, particularly control. So glycemic response during the first 12 weeks of basal insulin therapy is a predictor for mid to long-term glycemic control. And hypoglycemia following insulin initiation is also a predictor for long-term hypoglycemia risk. Let's look at some of this data. So the majority of titration, a number of studies have shown, this is a compilation of treat-to-target studies, 15 treat-to-target randomized controlled trials. The majority of titration occurred during the first 12 weeks in these trials. And these trials went all the way up sometimes to 24 weeks. And as you can see, the bulk of the insulin dosing in these trials, up titration, took place in the first 12 weeks. And there was really, so 150% of the insulin dosing took place in the first 3 months, weeks 0 to 12. And after week 12, there was only about a 12.5 increase in insulin dosing in this meta-analysis of treat to target trials. And so titration of insulin dose across these occurred predominantly during the first 12 weeks. In terms of glycemic response during the first 3 months of basal insulin therapy, it, as I mentioned, is a predictor for mid to long-term glycemic control. So many patients start basal insulin, as I noted in the study by Kunti, when A1Cs are above 9%. So that is the first form of clinical inertia or delayed intensification. And thereby, mean A1C tends to be quite high when you look at patients who are first started on basal insulin. In this particular study, between 8.5 and 10%, looking at a multitude of countries that were participating in this particular chart analysis study. 42% had A1Cs greater than 9% at basal insulin initiation. But the greatest decline in A1C occurred in the first 3 months before remaining stable for the subsequent time frame of up to 2 years, 24 months. So only 21% achieved an A1C at 3 months, but it really didn't improve thereafter, with 28% after 2 years. So it really goes to show you this is the time to get patients aggressively to target. And if you can do that, you can see here patients who got down to 7% stayed at target after the first 3 months for up to 2 years. So that first 3 months is the most important window when you first get a patient. That's your opportunity to get patients to target and keep them there. Hypoglycemia following insulin initiation is a predictor for long-term hypoglycemic risk. So risk of hypoglycemia after 24 months, if patients experience hypoglycemia within the first 3 months of starting on basal insulin treatment, is a predictor of future hypoglycemia. And this comes from this real-world practice study, looking again at the same countries, France, Germany, Italy, Spain, UK, and USA, where if you had hypoglycemia in the first 3 months, you can see that there was quite a strong predictor, 7 to up to 20 times greater, if experiencing hypoglycemia during insulin initiation is a predictor of future hypoglycemia. So again, choosing insulin and titrating effectively in that first 3 months is critical to try and mitigate risk for hypoglycemia, optimize diabetes control, glycemic control, and those are predictors of how patients will do in subsequent years. So that brings us to the BRIGHT study, and many of you, I'm sure, are familiar with this study. When the second generation basal insulin analogs came to the marketplace, Glargine 300 and Degludec, there was tremendous interest to understand what was the best insulin, because they're both excellent insulins. And so both companies carried out head-to-head trials, right? In a randomized controlled trial fashion. This is the gold standard to analyze and assess one therapy versus the other, especially in the same market space. And so the BRIGHT study compared U300 to Glargine 300 to Degludec. And it was the first head-to-head RCT designed to compare the efficacy and safety, as I mentioned, of Glargine U300 to insulin Degludec U100 in people with type 2 diabetes who were insulin naive. That is, these were patients failing on oral agents that needed to be put on a basal insulin. It was a multi-center, open-label, one-to-one randomized, active control, 2-arm parallel non-inferiority study in adult participants, as I mentioned, with uncontrolled type 2 diabetes. And the treatment period was 24 weeks in total. So these were the patients that were enrolled in the trial. These are the patients that you'd see in your practice on a regular basis, greater than 18 years, have had diabetes for at least a year, not at target. BMI, most of the patients were overweight and had to be on stable background therapy and no history of trying out insulin. And they were randomized in a blind active two-arm control fashion. The randomization was blinded, and they went on to either glargine 300 once daily with titration at nighttime, or insulin degludec 1 daily, also titration at nighttime. So you can see the numbers were quite equivalent in both arms, and you had this titration period, the first 12 weeks, and the maintenance period, which was the next 13 to 24 weeks. And then they were followed up at end of treatment study. So this was a non-inferiority design. That means that the goal was to effectively titrate patients in a treat-to-target fashion, and non-inferiority was met at week 12. You can see both groups effectively had effective titration, starting out with a mean A1C of about just above 8.5, and got down close to target by week 12. And the majority of patients achieved the A1C target of 7 by week 24, and there was no difference between patients receiving glargine 300 or insulin degludec. Excuse me. And so as this was a non-inferiority design, its primary outcome was met. But there were pre-specified secondary outcomes that focused on hypoglycemia. And here I'm going to show you them in the next couple of slides. And here we're looking at anytime hypoglycemia within a 24-hour time frame, and the data is presented in both incidence and event rates, which is how we often see hypoglycemia presented in a randomized controlled trial such as this. And you can see that during the full study period, there was no difference between the two second-generation basal analog insulins. They were both effective with very, very low rates of hypoglycemia. And during the titration period, there was in fact a statistically significant reduction favoring glargine 300 compared to degludec for level 1, that is less than 3.9 to 3 for level 1, and for level 2 hypoglycemia, less than 3.0. And these were statistically significant in the titration period, favoring glargine 300. And you can see, in fact, even when there was not statistical significance achieved for any time for the full study period and the maintenance period, it tended to be the left side favoring glargine 300 of 1 for both incidence and event rates. But it was statistically significant both in terms of incidence of hypoglycemia for level 1 and level 2, and event rates were also statistically significant during this titration phase, favoring glargine 300 over degludec 100. If you look at nocturnal hypoglycemia, again, overall, no difference between the two, but there was, for the event rate, there was statistical significance for level 1 hypoglycemia, less than 3.9, favoring glargine 300 over degludec. So those are the key safety parameters, pre-specified hypoglycemia data that came out of this particular study. Now there has subsequently, of course, this was presented at the ADA and EASD and has been published and is been disseminated in many presentations over the last couple of years. But there were subsequent analyses that were pre-specified that I want to share with you today that you may not know about, and that's looking at people in that have particular high risk, especially for hypoglycemia. So first, let's look at the analysis, the sub-analysis from the BRIGHT study, looking at renal populations. And there was a pre-specified analysis that was carried out where patients were, from the two arms, were also analyzed according to GFR category cutoff. So patients greater than equal to 90, and you can see the numbers are equivalent in the glargine 300 and degludec arm, 60 to 90 and less than 60. So 3 GFR categories looking at hypoglycemia in a pre-specified manner. And what we see here is that the change in hemoglobin A1C by renal function group was no different for patients between 60 to 90, very equivalent, but all achieving the same preferred, the ideal non-inferior outcome of an A1C around 7%. But interestingly, for patients who had worsening renal function, GFR cutoffs less than 60, there was a statistically significant difference in the number of patients achieving A1C target of 7 with lower GFRs favoring glargine 300. Now, this is an interesting finding, not totally explained to this day, but issues maybe around how insulin is cleared through the kidney. But to this day, at least I have not heard a clear explanation why, except that it is, somewhat reassuring that in fact these basal insulin analogs get patients to target effectively. But in patients with poor GFRs, in this particular study, there was a superiority demonstrated in the number of patients getting down to target. Numbers are relatively small as they were broken into the 3 groups, but still the findings are what the findings are. So the conclusions from this sub-analysis that patients receiving glargine 300 versus insulin degludec with type 2 diabetes and impaired renal function saw a greater A1C reduction with I didn't show the hypo data, but they had comparable hypoglycemia incidence rates over the full study. So even though this patient group that had GFRs less than 60 had more patients achieving A1C of 7%, it was not at the cost of increased hypoglycemia. Let's look at another high-risk population, and that's the elderly population. This is perhaps one group of our patient populations that's perhaps in the most poorly managed. And by that I mean they're often neglected, they're at high risk for hypoglycemia. We often don't detect hypoglycemia, especially in the frail elderly, because they get admitted to hospital with a fractured hip, but it could have been a hypo event that led to them falling. And the focus is on their injury, not the antecedent event, which can often be hypoglycemia. So it's really important to look at this, and in the BRIGHT study, they have done this. So let's just talk about this patient population. 26% of our patients with diabetes, type 2 diabetes, are over the age of 65. We know that older adults have higher rates of premature death, functional disability, and coexisting illnesses. Multimorbidity is the norm for this patient population. They're at greater risk for polypharmacy, cognitive impairment, urinary incontinence, injuries, falls, and persistent pain. And screening for complications should really be individualized and periodically revisited, including looking at their insulin therapy if they're on insulin. We also know that as people age, they lose their ability to have perception around hypoglycemia, and they become actually hypo-unaware. So this really beautiful study done a number of years ago shows that that patients in the yellow here who have I'm just going to look at my. Patients here have, if they're older, they lose their ability to detect the early signs of hypoglycemia and thereby are at greater risk for hypoglycemia or hypoglycemia unawareness. So let's look at the results from another sub-analysis of the BRIGHT study that compared data for participants less than 65 versus greater than 65. This was a pre-specified sub-analysis, and 70 versus less than 70 versus over 70, and this part of the analysis was post hoc, but really interested in looking at the more senior patient population. in the baseline characteristics, looking at those who were greater than or equal to 70 years, you had a pretty good number of patients in it, 74 and 87 in the two arms, and the mean age was around 74. Not surprisingly, they'd had long-standing diabetes, and their GFRs were pretty good in the 70 range. And again, typical of a patient population with type 2 diabetes, their BMIs were around 30. So what did we see in this post-hoc analysis? In fact, we saw that A1C reductions were greater in the patients receiving glargine 300 versus those receiving insulin degludec in this cohort of individuals greater than 70 years without an increase in hypoglycemia, just like in the last sub-analysis around patients with worsening renal function. We also saw in this study that patients who were older, i.e. greater than or equal to 70 years of age, achieved better A1C targets without increasing the risk of hypoglycemia. So interesting, and it was about a quite statistically significant difference in patients achieving the target of minus 0.34%. So the conclusion shown from this poster, and to my knowledge, I don't think it's been published yet, but it was presented at the ADA a couple of years ago. The patients greater than or equal to 70 years old showed greater A1C reductions with Toujeo without the increased risk of having increased hypoglycemia versus insulin degludec. So, as I mentioned, there were two RCT head-to-head trials, and Novo Nordisk also carried out their own head-to-head RCT comparing glargine 300 to insulin degludec, and this was called the CONCLUDE study. And it was presented 2 years ago at EASD, and is a study that still does not have a clear conclusion because of challenges during the trial. The CONCLUDE trial design was very similar in that patients were randomized, in this case using degludec U200 to glargine 300, but the difference one of the big differences between CONCLUDE and the BRIGHT study is in the BRIGHT study, patients were insulin naive, they had not been on insulin, and in the CONCLUDE study, these are patients already on a background of basal insulin. As a large study of 1,609 patients, they were taken off whatever pre-existing basal insulin they were on, and they were randomized to either degludec U200 or glargine U300. There was a 16-week titration period and a 36-week maintenance period. And again, it was a treat-to-target non-inferiority design with pre-specified hypoglycemia as a pre-specified outcome as well. Open label like BRIGHT study, and the total treatment period was to be 1 year. There were all sorts of problems with this trial, which is why it's so hard to conclude what the results from CONCLUDE show. Partway through the trial, there was an acknowledgement and an understanding that the meter they were using was displaying falsely higher results in the hypoglycemic range. So the meter was under-detecting hypoglycemic events. The meter numbers were reading higher than, in fact, what the blood sugars were. And so the protocol was amended to include a new 36-week extended maintenance period, and everybody was switched over to a new meter midway. It made this whole time frame very difficult to interpret when you're looking at comparing insulin, the two insulins and hypoglycemic events when you have a meter that's not capturing it accurately. So it made it very challenging to understand what the hypo numbers meant. At the end of the study, it showed the same outcomes that the BRIGHT study did, that these are both excellent, the second generation basal insulin are both excellent with low rates of hypoglycemia, can effectively get patients to target, but they in fact did not demonstrate any differences between the two arms in terms of hypoglycemia rates. And this was a study that was designed for superiority if the non-inferiority was met, getting patients to target, then secondary analysis to look at superiority of U200 degludec versus glargine U300 for symptomatic or severe hypoglycemia. But because of the trial challenges, the results are very hard to interpret, except that they had low rates in both arms, and there was no statistical significant differences between the two arms, and superiority therefore was not.
I'm sorry to interrupt, Dr. Professor. We have like 2 minutes because of other sessions.
Yep, I am finished.
Okay, thank you so much.
Thank you. So I'm not sure if we have time for questions or how I can handle this for you now. You let me know.
I mean, you can keep answers, and we'll publish it on the site or somewhere, so that later, because we have like we are running little short of time because we have another schedule going on.
So I see one question here. Is there a maximum dose for basal insulin above which no benefit? There is no upper limit to what you can prescribe. And, we run into this challenge in patients with who are quite morbidly obese and quite insulin resistant. But usually when, you get patients into the 100, 120 unit range, it's really important to consider adding either bolus insulin or GLP-1 for sure. And I think because our time is up, I'll be happy to answer any other questions that get sent in to me, and the organizers can forward those along to me. So I'd like to thank you. I'd like to thank all of you for your attention. Hopefully you found this useful, and it's been a pleasure to visit Kuwait today. I hope to do it in person post-COVID. Take care and have a great program.
Thank you very much, Professor Stephen. Thank you so much.
Thank you.
Yeah.
بسم الله الرحمن الرحيم والتين والزيتون وطور سينين وهذا البلد الأمين لقد خلقنا الإنسان في أحسن تقويم ثم رددناه أسفل سافلين إلا الذين آمنوا وعملوا الصالحات فلهم أجر غير ممنون فما يكذبك بعد بالدين أليس الله بأحكم الحاكمين صدق الله العظيم.
بسم الله الرحمن الرحيم. الصلاة والسلام على سيدنا محمد. يسعدني اليوم أن أكون مع إخواني الأطباء في مستشفى الأميري لمؤتمرهم الثامن للسكري تحت مسمى مرض السكري وجائحة كورونا. عادة لما نتكلم عن مرض السكري وحسب ما احنا عارفين أن أحد الأمراض المزمنة اللي أوصت منظمة الصحة العالمية بالقتال معها، ليس فقط العلاج ولكن القتال معها لتخفيف أعبائها، وكلنا عارفين الأشياء اللي تسببها أو المضاعفات اللي يسببها مرض السكري سواء بالعين ولا بالكلى ولا غيره. شاكر لي مستشفى الأميري على جهودهم خلال ال8 سنوات هذه. أحب أشكر كذلك اللجنة المنظمة على رأسها الدكتور عبد النبي العطار، كما أشكر الشركات الداعمة لهذا المؤتمر على مجهودهم، خاصة حنا في وقت كورونا والتراس أو المؤتمر راح يعقد عن طريق التواصل الاجتماعي، وهذا قدر وسنة الحياة خلال فترة كورونا. شفنا شلون كورونا خلال السنة الماضية هذه كيف تطوراتها وشنو النتائج اللي عملتها، أعدادها الكبيرة في جميع أنحاء العالم، الوفيات الكبيرة، فجائحة لا يستهان بها. إذا أضفنا لها مرضى السكري الخطورة راح تكون أعلى، نحتاج اهتمام أكثر بهذه النوعية من المرضى. وأشكر جميع الأطباء، خاصة احنا محتفلين قريبا في يوم الطبيب العالمي، أتمنى الصحة والسلامة للجميع وكل عام وانتم بخير. مثل ما شفنا خلال الفترة طريقة التعامل مع يعني خلال جائحة، كيف تعاملت دولة الكويت مع مرض السكري والأمراض الثانية، توصيل الأدوية وغيره. السياسات الدولة اختلفت للتعامل مع هذه الأمراض. الأطباء بذلوا مجهود كبير سواء في محاربة الجائحة أو في محاربة المرض، مرض السكري وغيره. شغلة ثانية، الكويت خلال فترة الجائحة وهم من قبل فترة الجائحة وفرت أفضل أنواع الأدوية والمعدات اللي يحتاجها سواء مريض السكري ولا الأمراض الثانية. وفرت أفضل أنواع الأدوية للمرضى. نحتاج ثقافة ونحتاج بعض الإنصات من المريض نفسه حتى ما المريض ياخذ نفسه في مشاكل وتعقيدات مرض السكري اللي نعرفها جدا مؤذية للشخص وللعائلة وللجسم الطبي. بس نقطة أخيرة حبيت يعني أنوه لمرض السكري من النوع الأول، وإحنا عارفين خطورته حيث أنه يبتدي مع الطفل ويكبر معاه. أتمنى من إخواني في أقسام السكري يحطون لنا إطار أو آلية أو بروتوكول لهذه النوعية من المرضى لنقدم لهم حياة أفضل. يعني ما نبي نشوفهم على 30 سنة 20 سنة وهم يعني فاقدين البصر ولا فاقدين الكلى. أتمنى أن نحط لنا إطار معين لهذا الموضوع. أتمنى لكم الصحة والسلامة والعافية. الله يحفظكم. Good evening, ladies and gentlemen. It gives me a great honor to be with you today in starting your conference. I wish you all the best, a successful conference. Just 2 points I'd like to mention here. The first point, that we need to educate the people about the diabetes, the complications of diabetes, plus now we have diabetes plus corona. So we have to educate our people so that they know what is their future once they are diabetic. Second point, diabetic type 1. All of you to put a protocol for such patients. We don't want them, we don't want to see them at 15, 20 years where they lose their eye vision or they lose their kidneys. So please put your protocols, arrange for such type of patients. Wish you a successful conference and enjoy your conference. Thank you very much.
Can I start now, Mr. Mustafa?
Abdul, you can start.
Yeah. بسم الله الرحمن الرحيم. السلام عليكم جميعا. سعادة الدكتور الشيخ باسل الصباح وزير الصحة المحترم، أخونا وزميلنا وابن الأميري دكتور محمد الخشتي وكيل وزارة الصحة المساعد لشؤون التخطيط والجودة والتخطيط والجودة، حضورنا الكرام، زملائنا، حياكم الله ومساء الخير. لمؤتمر السكر الثامن لوحدة السكر في مستشفى الأميري قصة حقيقة. احنا بدأنا سنة 2014 بالمؤتمر الأول، والحمد لله رب العالمين التوفيق من الله عز وجل ودعمكم ودعم زملائنا الأطباء من كافة التخصصات. الحمد لله استمر كل سنة وبصورة أحسن من التي سبقت. أهمية مؤتمر السكر السنوي اللي تقيم وحدة السكر في مستشفى الأميري نابعة من وضعية السكر في العالم ككل وفي الكويت بصورة خاصة. الكويت حاليا تعتبر من ضمن 10 الدول الأوائل التي ينتشر فيها مرض السكر. تقريبا نسبة الانتشار عندنا بحدود 20% ماينس بلس، يعني كويتي من كل 5 مصاب بالسكر بصورة أو بأخرى، وهذا شيء طبعا لا نفخر فيه، ونحاول دائما إن شاء الله يعني نعدل هذه النسبة إلى الأقل إن شاء الله. جانب آخر أن في الوقت الذي نعاني فيه من جائحة مرض السكر استجدت لنا جائحة أخرى من السنة اللي فاتت اليوم، اللي هي جائحة مرض كورونا، والتي اجتاحت العالم ككل بما فيها بلدنا الحبيب. حاليا على مستوى العالم عندنا بحدود أكثر من تقريبا أكثر من 130 مليون مصاب بالسكر بكورونا، والوفيات بلغت أكثر من 2.5 مليون للأسف الشديد. بينما فيما يتعلق بالنسبة حق الكويت، فالإحصائيات تقول بأن حتى الآن عندنا حدود 235 ألف مصاب، وللأسف الشديد حدود 1330 إنسان توفي بهذا إلى رحمة الله بهذا المرض، الجائحة، جائحة كورونا. وبالتالي حقيقة مع جهود وزارة الصحة الملاحظة وبصماتها الواضحة في مقاومة المرضين، مرض السكر ومرض الكورونا، إلا لا زلنا بحاجة إلى المزيد من الجهود لكي نحتوي هذين المرضين. وأحد الواجهات الأساسية لمقاومة هذا المرض هو زملائنا الأطباء والسيسترات وكل العاملين في القطاع الطبي. وبالتالي تأتي أهمية هذا المؤتمر، والذي سوف يشارك فيه زملاء من داخل الكويت ومن خارج الكويت ومن أوروبا بشكل محاضرات لتقديم آخر ما استجد من داتا وأبحاث فيما يتعلق بهذين المرضين، خصوصا إذا علمنا بأن اشتراك المرضين للأسف الشديد مخرجاتها سيئة جدا. يعني الكورونا بحد ذاته مرض سيء، السكر مرض سيء في المخرجات، اجتماعهم مع بعض لربما يؤدي إلى مضاعفات سيئة الواحد ما وده أنها يعني تصيبه يعني. وبالتالي في هذا المؤتمر إن شاء الله والذي سوف يقام على مدى 3 أيام عن طريق البرامج التواصل الاجتماعي أو عن طريق عن بعد، سوف نقدم لكم مجموعة محاضرات على مدى 3 أيام يقدمها مجموعة من كبار الأخصائيين في كافة التخصصات مثل ما قلت قبل شوي في الكويت وخارج الكويت. ختاما أحب أشكر الحقيقة كل من ساهم في إقامة هذا المؤتمر الذي هو عبارة عن مجهود جماعي الحقيقة، وبالتالي أخص راعي الحفل سعادة الدكتور الشيخ باسل الصباح وزير الصحة المحترم، أخونا وزميلنا الدكتور محمد الخشي الوكيل المساعد بوزارة الصحة، وأيضا أشكر اللجنة المنظمة التي حقيقة قامت بجهود جبارة في تنظيم هذا المؤتمر. أيضا أشكر الأخوة والزملاء في الاندستري في الشركات الراعية، وأيضا أحب أشكر أيضا شركة ديزاين ماستر على تنظيم هذا المؤتمر. شكرا لكم، ونتمنى لكم إن شاء الله مؤتمر مثمر ومفيد بإذن الله. والآن سوف ننتقل إلى أول المحاضرات والتي سوف يرأسها الدكتورة مريم الراجحي، استشاري أمراض باطنية ورئيس وحدة أمراض الباطنية في مستشفى الأميري، وأيضا الدكتورة عائشة الفهد، استشاري أمراض باطنية وغدد صماء في مستشفى الأميري. دكتورة مريم, the ground is yours. Go ahead, please.
Okay, so good evening, everyone. Allow me to welcome our first speaker for today. Dr. Bassam Abul Banat is currently a consultant of cardiology at Sabah Al Ahmed Cardiac Center in Kuwait. He has pursued his postgraduate training in internal medicine, cardiology, and echocardiography in Canada. During his academic career, he has contributed to several international journal publications. He is currently posted as the chief of the exam committee of the Kuwaiti Board of Adult Cardiology Fellowship Program. Welcome, Dr. Bassam, and the floor is yours.
Thank you very much, Dr. Aisha. Can I share the video? No. Do you see my slides?
Yes, we do.
You are seeing my slides?
Yes.
Okay.
We are unable to see your video, Dr. Bassam.
I'm sorry?
We are unable to see you.
Well, you took me out of the video because that's why, I think. Because somebody took me out of the video. Okay. Do you see me now? Do you see me now?
No, not yet.
Well, I'm seeing.
Okay.
Okay now?
Yeah.
No,
yes,
no,
okay.
go before that. We've seen you before that.
Okay. Now you are seeing me now?
Yes, yeah, we can see you, yes.
Okay, then. Okay. Thank you very much, Dr. Aisha, for the introduction. Again, my name is Dr. Bassam Abul Banat. I'm a cardiologist in Sabah Al Ahmed Cardiac Center. I've been given this task to talk about cardiovascular disease, diabetes, with regard to the COVID-19 patient. I chose to call it friends or foes, and by the end of the talk, I'm going to repeat the same question, and you have to decide whether they are friends or foes. So the objective is to review the major epidemic of diabetes and high rates of cardiovascular disease in the Gulf. Then we're going to talk about the correlation of COVID-19 and diabetes. Then I'm going to talk about the link between the three devils. This is going to be a very shaky journey. I'm going to shake you up and down. It's not going to be through the usual presentation because I thought it's going to be boring. So I'm going to do it in a way I hope you like it. Let's start with our journey. Now, it was, I think, on the 22nd of February, we had a meeting in the new Amiri building, and we were about to launch our out-of-hospital primary PCI through collaboration with our primary care physicians. And we were aiming to basically hit one of our objectives in Kuwait with regard to combating non-communicable diseases, which are diabetes, cardiovascular disease, chronic respiratory diseases, and cancer. So we were aiming to have something. Then next day, this guy came. So it was 2020. Now it's 2021. And it seems to be that's going to go to even 2022. We don't know where is it going to come. So suddenly the pandemic shifted from non-communicable diseases to communicable diseases. So before 2020, diabetes was our epidemic. Actually, it was our pandemic. Then by 2020, COVID became our pandemic. So let's start our journey. I'm going to take you through scenes. So this is, I'm going to call the epidemiology scene. And through those scenes, you're going to understand the similarities and dissimilarities with regard to the COVID, diabetes, and cardiovascular disease. Now we know that cardiovascular disease mortality rates are related to raised blood pressure and diabetes prevalence, which is very clearly seen here. The message here is that the dots in orange rod represents basically low-income countries. And if you are to the left of the curve, it means that your mortality is lower. To the right of the curve, your mortality is higher. If you are coming from a high-income country, the chances that you're going to have raised blood pressure and diabetes should be low. Hence, your mortality should be lower. But if you are coming from a low-income country, your mortality is going to be higher. And to confirm that gradient, if you look at patients with type 1 diabetes mellitus, those are younger patients. Even in those patients, up to 16% had a history of cardiovascular disease, 2% had a history of stroke, and 1% had a heart attack. If you're going to jump now to the middle-aged people, those are which countries? Those are the high and middle income. So those are the countries where we expect to have lower mortality. Those are the countries you should expect to have better care. Even in those countries, up to 41% of them had cardiovascular disease, 10% had a stroke. Remember, it was 2% in type 1 diabetes, and 14% had a history of myocardial infarction. So that was with regard to the epidemiology of diabetes and cardiovascular disease. What about COVID? There was a meta-analysis of 6 studies in COVID-19 reported the prevalence of the following diseases: hypertension, 17.1%, cardiac and cardiovascular disease and cerebrovascular disease, 16.4%, diabetes, 9.7%. So there are similarities. Diabetes had a lot of cardiovascular diseases as well, in the form of prevalence, as well as COVID-19. Actually, patients who required ICU admission were more likely to have these comorbidities than non-ICU patients. So again, there is a gradient to that. This is the second scene. I called it the paradox scene. Confusing, sure, no? And I'm going to tell you why is it called the paradox. It's very confusing. Now, when it comes to diabetes, those are the country characteristics and the age-adjusted cardiovascular disease mortality, which goes with the initial slides which I showed you. If you are coming from a low-income country, you have higher prevalence of blood pressure and diabetes, then you're going to have higher rates of cardiovascular death and mortality. And if you are coming from a higher income country, you're going to have lower incidence of cardiovascular disease, and because you have basically better non-communicable disease monitoring systems. Having said that, imagine this is not the case in the Gulf. The Gulf is we have high income countries, but again, our mortality, which I'm going to show you later on, is higher with regard to that. So that's one paradox. What about COVID-19? When it comes to the COVID-19 and the mortalities, we cannot talk about it just universally. Actually, we have to look at it in two waves. So I'm going to call it the waves of the pandemic, and it ends up with the war of vaccines. The first wave was actually, if we're going to go exactly 1 year back, we were probably at the beginning in Kuwait, at the rise of the first wave. The whole world was at the peak of the first wave. So the developed countries, mainly Europe, were hit hardly by this time with the wave. The developing countries, if you remember, they didn't know what was going on. They were lagging behind. Actually, everybody was thinking that disease was mild there. It was not going to hit them. Then we had the second wave, which I'm going to call the pre-vaccine wave. The second wave, the developing countries catched up with the developed countries. The developed countries were hit by the tsunami, actually. You remember what happened in December and beginning of January, and before November, December to Europe and North America, they were hit by a tsunami wave. And that's when we had the mortality very high in North America as well as in Europe. Then we have the third wave, which we are experiencing now. Actually, some of the countries are going into probably beginning of the third wave. Now you have a trichotomy. It's not a dichotomy. You have the vaccinated developed countries truncated the wave, which are the US and UK. Those are the leaders. Then you have the lagging behind developed countries, which are still vaccinating. Those are the rest of Europe. Probably you're going to include some of the Gulf countries. Those are waiting for the third tsunami to hit them. Those are the followers. And you have the developing countries, which are embracing the disaster. They have not yet seen a vaccine. And a clear example is Brazil, and those are in the land of nowhere. So when it comes to the epidemiology, they are not similar. There are a bit of similarities, but there are a bit of dissimilarities. Within each disease, there is a paradox there. So now I'm going to take you to this next scene, which are the mechanistics. Maybe here we're going to talk about some similarities with regard to the COVID and diabetes, and we're going to see here the link. So when it comes to the similarities in the cardiovascular damage and COVID-19 and diabetic cardiovascular damage, that's because the mechanisms that lead to cardiovascular disease overlap with pathways that regulate the immune function. And that's a mutual between diabetes and COVID-19. That's why you have that. I'm going to give you 3 examples. The first example is age. We know that age is the strongest risk factor for cardiovascular disease, and the effect of aging on the immune function may be equally important for COVID-19 susceptibility and severity. At the same token, we know that age for COVID-19 is a bad thing. If you are older, beyond the age of 70, your mortality goes exceedingly high. So the effect of age on the immune system has been previously shown by the low protective titers among 50% of adults older than 65 years who received the influenza vaccine. Remember, that was one of the fears when we got basically the COVID vaccine, that in the elderly, they might not mount a good immune response. The second example are the traditional risk factors. Other traditional risk factors, such as diabetes, hyperlipidemia, there are non-risk factors for cardiovascular disease in diabetic patients. But when it comes to the COVID, those are the same factors that can affect your immune function and conversely dysregulate the immune status, resulting in a higher risk of cardiovascular disease in the COVID population. So that's the link. Number 3 is that we're going to look at the trigger pathways that contribute to the outcomes in cardiovascular disease. Now, remember our famous ACE2, probably all of you know, you heard about it, is that because of the higher expression of ACE2 in patients with hypertension and cardiovascular disease, it's the same receptor that SARS-CoV-2 gets the entry to our system, that there was postulated that there is an enhanced susceptibility to the COVID in patients with cardiovascular disease. To make this picture complicated, there is a new meta-analysis which is called the BRACE Corona. I don't know if you have heard about the trial. And in this trial, they actually, they downgraded the clinical implication of ACE inhibitors in patients with COVID. So you can still prescribe it because it's not as we thought. So still, that's only a theory. Let's look now at the basically mechanisms. Those came from a recent article. I've just put for the quotation for you. And this is basically, I thought those basically 3 slides gonna explain to you the possible mechanistic pathway of the severity between cardiovascular disease, COVID-19, and the role of ACE in the COVID-19. So what you are having here, you have basically the COVID-19 infection. It can exert its effect through either the ACE2 or through increased D-dimers. ACE2, you're gonna have severe infections, D-dimers, hypercoagulability, pulmonary embolism, hypoxia, heart failure. And at the same token, cardiovascular disease can exert its different effects through those 3 mechanisms: ACE2, D-dimers, and acute coronary syndrome. And that's why they are linked. So both diseases, in a way, mechanistically, they are linked with each other. What about the link between diabetes and COVID-19? It's the same thing. Here, the link is much more clearer. So you have diabetes mellitus. You know that patients with diabetes, they have basically phagocytic cell dysfunction. They have impaired T cell, altered cytokine production, ineffective microbial clearance, neutrophil chemotaxis inhibition. And that's all lead to immune dysfunction. And that's the hallmark of the COVID-19 infection, which leads to severe illness. So what you are having here, a double whammy, if you'd like to say. Diabetes will lead eventually to a basically immune dysfunction. COVID-19 will lead to immune dysfunction. So if you have both of them, you're gonna have a double whammy. And that's why you're gonna have a bad effect. What about of the role of the different markers in the COVID-19? Those are the markers that we talk about. Interleukin 1, interleukin 6, tumor necrosis factor alpha, C-reactive protein, D-dimer, fibrinogen, all of them will lead to a prolonged cytokine storm with a severe illness. And they are all linked to both diseases, diabetes as well as COVID-19. So I'm gonna take you now to the next scene. This is, I call it the bread and butter scene. This is the clinical, basically, scene. So now we're gonna talk about the clinical implications of diabetes with regard to cardiovascular complications, as well as COVID with regard to cardiovascular complications. So we'll start with diabetes. We know that, all of you know that, basically, that diabetes is strongly related to cardiovascular disease. You're gonna have a higher chance of having coronary heart disease, coronary death, ischemic strokes, be it embolism or hemorrhage. So diabetics have much worse outcomes with regard to those things. Actually, over the past decades, we have seen a decline in the mortality, be it all-cause mortality or death from cardiovascular diseases. But despite this decline, still patients who have type 2 diabetes mellitus, they are at a higher risk. So it is still unexpectedly high. We're not doing a good job yet. This is a very famous slide from Hafner that was a study which was published in the New England Journal of Medicine 1998. In this slide, this was the first slide that showed us that patients with diabetes without a prior MI, they have the same risk with regard to cardiovascular endpoints as if somebody who's non-diabetic who had a myocardial infarction. That is why we say that diabetic patients without an MI, as if they had an MI. What about heart failure? It's the same thing. Diabetes is the most important determinant of development of heart failure compared to other risk factors. If we're gonna look at the Gulf area, what's going on in our region? We know that 40% of the patients admitted with acute coronary syndrome in the Gulf area, they have type 2 diabetes mellitus. And this relationship is actually worse in ladies. 55% of ladies admitted with ACS in the Gulf region, they have type 2 diabetes mellitus. When it comes to the comorbidities, if you have type 2 diabetes mellitus, you have more chance of having COPD, stroke, dialysis, PVD. That's a deja vu with what's happening with the COVID. Those are the same bad playmakers in the COVID disease. If you have diabetes, you have more chance of having other risk factors. You have more chance of having hypertension, hyperlipidemia. So you are having a cluster of the bad risk factors. The end result is going to be very, very clear. You're going to have more chance of having CHF, ventilation, cardiogenic shock, stroke if you have diabetes. And it's the same thing that you're going to see what happens in the COVID-19. And the last thing is that it's going to end up with more mortality. So patients who were admitted to the hospital with ACS, they had a higher mortality compared to non-diabetics in the Gulf area. What about Kuwait? Well, in Kuwait, the Gulf, you remember, 40% of our population had basically diabetes who had an ACS. In Kuwait, 50% of patients who hit the hospital with ACS have type 2, have basically diabetes mellitus. The same thing is for the heart failure. What I want you to look at the blue and the red lines. The blue represents the age, so that the Gulf race. So our patients who are admitted with acute heart failure in the Gulf, they are younger by 1 decade than the rest of the globe, and they have 50% chance of type 2 diabetes mellitus. It's the same thing as what's happening with basically coronary disease. What about the mortality? This is the 6-month mortality. It is similar, but that's a bad news because our patients are younger, so you would expect them to have less mortality. What it tells you is that our patients, they have multiple risk factors and they die earlier than the rest of basically the globe because of those risk factors. And that's the end point, is that you're gonna see patients dying at younger age group. Let's see what's happening now. It's your turn. So it's the turn of the COVID-19. Let's see what's happening with the COVID-19 and the cardiovascular diseases. So basically, what you are seeing here is that those are the risk factors for the COVID-19, and those are the potential cardiovascular manifestations. I'm going to go through this one by one. Those are the risk factors. We said if you have a prior cardiovascular disease, immune activation, metabolic disarray, that is basically in the form of diabetes, coagulopathy, immobility. Those are the possible cardiovascular manifestations. Myocarditis, myocardial injury, arrhythmias. Usually we leave that for the hematology. Stroke is for our neurology colleagues, heart failure, and acute coronary syndromes. Let's start with the myocardial injury. Myocardial injury is detected by an increase of troponin level. So it is diagnosed with a troponin level. There is a recent study, which was an MRI study, and what they found is that 50% of COVID infection patients, they have some sort of a myocardial injury by MRI. The mechanism is either a direct injury due to the high affinity of the COVID-19 to ACE, which is widely expressed in the heart, or the cytokine storm. The belief it's more of the cytokine storm rather than a direct injury. The other thing is that the high troponin is not only a diagnostic tool, it becomes a prognostic tool in the COVID-19 patients. What about myocarditis and pericarditis? Myocardial infection by COVID-19 was not proven in most of the cases. Actually, I came across a case from the pediatric literature that they could isolate COVID-19 from the myocardial cells. And that was about 2 to 3 months ago. And it was the first case series that could isolate COVID from a myocardial cell. There is no consensus that exists on the appropriate treatment of myocarditis. Usually it's supportive therapy. The same thing as you're treating COVID. So you go with the steroids, antiviral, and if they are sick, you're going to end up putting them on probably ECMO, etc., etc. Pericardial effusion remains an uncommon finding, and a few cases of tamponade have been reported. What about the angiographic patterns and prognosis of STEMI in the COVID-19? STEMI can be the first clinical manifestation of COVID-19 disease. We've seen that a lot in Amiri Hospital. And geographically demonstrated the absence of obstructive coronary artery disease in 40% of the cases. This was basically the study that was done by Bangalore from New York. And what they have found is that 40% of their STEMI patients, they had no obstruction, they had just clots in the coronaries. And that's what differentiates the basically STEMI in COVID-19 from STEMI in the diabetic patients. And the reason is that probably because it's microvascular thrombosis that leads to that rather than anything else.
Sorry, you have
What
5
about
minutes,
cardiac?
Dr. Bassam.
I'm sorry?
You have 5 minutes.
Okay. Then you have the cardiac arrhythmia and the cardiac arrest. The cardiac arrhythmias are related to the high level of troponin, and those are associated with malignant arrhythmias. Probably that denotes myocarditis. And cardiac arrhythmias were also observed in hospitalized patients and more common in the ICU patients, which makes logic now because those are the sicker patients. Patients with in-hospital cardiac arrest present usually with asystole and non-shockable arrhythmias rather than shockable arrhythmias. What about cardiomyopathy and heart failure? Heart failure as STEMI has been reported as the initial presentation. I've seen that maybe in a couple of cases with myocarditis. In STEMI, we had troponin. Here we have the elevated BNP as your prognosticator. Whether heart failure is most commonly due to the exacerbation of pre-existing LV systolic dysfunction or a new cardiomyopathy still is unclear. Cardiogenic shock, usually it's a mixed picture. We have right now a patient in our CCU with a mixed picture, cardiogenic and septic. And here, you're gonna be looking at the BNP and echo to help you differentiate between the two. Those are some of the considerations for the cardiovascular healthcare workers during the COVID pandemic. Basically, we all shifted to the electronic health system. We are adherent to the PPEs. We are limiting our elective procedures just to combat this disease. Those are some of the key cardiovascular society recommendations. You're gonna notice a lot of them, they are talking about hypertension because of the fear of the ACE inhibitors and ARBs. And I can assure you now, based on the most recent randomized trial, that there is no fear of putting in those patients on ACE or ARBs. So that's not gonna put your patient at risk. This is from a Canadian article which shows you the proposed diagnostic workup and subsequent management of the most common or life-threatening cardiac manifestations. So you're gonna have your patient hitting all of those investigations. He's gonna end up being one of those for either a PE, ACS, acute heart failure, cardiogenic shock, AFib. It's an arrhythmia, you're gonna treat it with antiarrhythmics and shock, cardiogenic shock and heart failure. You're gonna give them vasopressors. They could end up with ECMO. Acute coronary syndrome, you're only gonna take these very sick, high-risk patients to the angio suite. PE, you're gonna basically thrombolize those patients. Well, at the end of the point, both of the diseases, COVID-19 and diabetes, they are gonna end up the same endpoint. They both die at a young age. Is there a light at the end of the tunnel? We know that those are the strategies to decrease the impact of diabetes and cardiovascular disease. That's for non-communicable diseases. We were talking about healthy eating, physical activity, decreasing tobacco smoking, reducing, controlling blood pressure and diabetes. But in COVID, vaccination is probably our best strategy to combat COVID. And just to end you with another confusion, SGLT2s, actually, if you're gonna look at the SGLT2s with regard to type 2 diabetes mellitus and COVID-19, you're gonna have lots of articles talking about the benefit of SGLT2s as anti-inflammatories in COVID-19 and for type 2 diabetes mellitus. However, when they implemented in the clinical ground, this is basically a paper from Boston, it's from Boston. And what they have found is that they had 5 patients who had COVID-19 on SGLT2s. They developed ketoacidosis with euglycemia. The treatment is easy, just you withdraw the medication. We are waiting right now for a bigger trial. It's called the DARE-19 trial. That's the dapagliflozin in patients with COVID, to look into that. So with that, I come with the conclusion. I'm going to leave you with this question. So do you think that COVID-19 and diabetes are friends or foes? Thank you very much.
Thank you so much, Dr. Bassam, for very informative lectures as always. We have a couple of questions, if you don't mind.
Yep.
So the first one says, diabetic patients who recovered virologically from COVID-19, do they need screening for myocardial damage to rule out post-COVID syndrome?
Yep. Now, in my clinical practice, I'm having a low threshold of doing echoes in post-COVID patients if they have any residual inappropriate tachycardia, which is common, by the way. We're seeing that quite commonly, sinus tachycardia post-COVID, or any residual SOB. At the end of the day, echo is a very simple, non-invasive test, safe test, and it's not among the tests that are basically prohibitive or not asked to be done in the COVID patients. Now remember, ETT is a test that is discouraged to be done in the pandemic because of the risk of, during the stress test, the people get exhale. So if they have the virus, they could infect other people. But echo is a safe test. I'm doing it a lot, and I have a low threshold because of that. And I've seen a couple of cases who had probably myocarditis around the COVID infection. That was even post-recovery. I've seen a case a month after recovery with LV systolic dysfunction without any other explainable causes.
Thank you. There's another question. What are the most common causes of mortality in post-COVID infection, i.e. in those who recovered initially from the acute infection? Is it PE or arrhythmias? No,
they are talking about cardiovascular, no? Now, I mean, if they recovered, I haven't seen, actually post-recovery, we haven't seen arrhythmias. The arrhythmias, they happen acutely. The ones that we have dealt in our basically, I think in the first wave and the second wave, probably the cardiology and the medicine colleagues, they know that because they've looked after those patients. Probably our ICU colleagues, they know that as well, is that was during the acute phase, only during the acute phase. But following recovery, definitely I haven't seen arrhythmias. And the PEs, probably our medicine colleagues, they're going to be better in answering that, is that some of the patients following recovery, those are the bad ones, maybe had some residual clots and they had another PE afterwards. But definitely arrhythmias are an acute issue. They happen acutely, but not following recovery. Sure.
There's one last question, Dr. Bassam, to try and keep our conference on time. Do you advise that we DC SGLT2 in patients with COVID infection?
Now, no, definitely, because there is an ongoing trial on. You should not DC it. What I showed you from Boston is that they wanted to raise a red flag that be careful when you give the SGLT2s to COVID-19. They've seen decaying in euglycemic patients. You have the DARE-19 study still ongoing on. So we have to wait for that because that's a randomized trial. We should not stop something that we based on only case series. But the case series, once you see them, it makes you more vigilant. If you had probably a bit of ketones up, so maybe that's a red flag that maybe your patient is going to develop TKA. And that's for our, I think, diabetology and endocrinology colleagues rather than for me.
Thank you so much, Dr. Bassam.
Thank you, Aisha.
Okay, so I would like to welcome our second speaker for today, Dr. Anas Youssef. Dr. Anas is the head of nephrology and dialysis center at Amiri Hospital. He has the Canadian Board certificate in internal medicine and nephrology from the University of British Columbia, Vancouver, Canada. He also is the vice president of the Kuwait Nephrology Association. Welcome, Dr. Anas, and the mic is yours.
Thank you, Aisha. Good evening, ladies and gentlemen. Actually, I'm privileged to be among the speakers in this symposium. Thank you for the organizing committee for inviting me. Let me just share my slides. So please let me know, can you see my slides?
Yes.
Great, thank you very much. So I was asked to talk about COVID-19, diabetes, and the kidneys. Trying to find a link between them. We all know that diabetes is prevalent, and it is an independent risk factor for many diseases, mainly cardiovascular and kidney diseases. So let's start with some definitions. To define chronic kidney disease, CKD, we know that CKD is an abnormality in the kidney function, low eGFR, less than 60 ml per minute for more than 3 months. Diabetic kidney disease is a relatively new term that you're going to hear a lot because of these new era of the SGLT2 inhibitors and diabetic kidney disease. But basically, it is just CKD in a diabetic patient. We need not to confuse it with diabetic nephropathy, because diabetic nephropathy is mainly when we have a histopathological diagnosis. So if we have a patient who underwent a kidney biopsy and we found some diabetic changes like diabetic nodular sclerosis, for example, then we can label the patient as having diabetic nephropathy. But diabetic kidney disease is more of a clinical term, just CKD in a diabetic patient. As I said, diabetes is prevalent and it is projected to increase significantly in the next 25 years by 50%. Most of this increase is happening in the Middle East and Africa. We can see that in the Middle East, we're going to have more than 96% increase in our cases and more than 100%, 143% in Africa. So this will carry more burden in our healthcare systems. Diabetic patients are at risk of developing chronic kidney disease. About 50% of diabetic type 2 patients, 50% of type 2 diabetic patients will suffer from chronic kidney disease in their lifetime. About 20% of those may go on and reach end-stage kidney disease and require dialysis. And in fact, if we go to our dialysis units, whether in Kuwait or in the region, we'll find out that about 50 to 55% of the dialysis patients do have diabetes, especially diabetes type 2. That doesn't mean that diabetes was the cause of their end-stage kidney disease, but it just showed how prevalent the disease is among our community. It has serious consequences, mainly increasing morbidity and mortality, especially cardiovascular mortality. So diabetes also is known to be the main cause of end-stage kidney disease. About 40% of the end-stage kidney disease causes is due to diabetes, followed by hypertension, about 25%. So diabetes is prevalent. It is the main risk factor for end-stage kidney disease. We wish to have to lessen that, and in this new era of the new therapies, SGLT2 inhibitors, GLP-1 receptor agonists, I hope we see less progression and more preservation of the kidney function in those patients. Now, March 2020, WHO declared COVID-19 as a pandemic. And at that time, it was a new virus, a new disease, highly contagious. We were seeing that cases were rising rapidly, and it was global, all over the world. So we, as nephrologists, we were thinking, how can we protect our patients? We have dialysis patients. They are going to dialysis units 3 times a week. We have glomerulonephritis patients, so like lupus or ANCA vasculitis. They are on immune suppression. So we need to protect them and help them to get out of this pandemic. So there were many things that we were thinking about, but the main one was the acute kidney injury. The incidence was quite significantly high among the general population. So the main one was acute kidney injury, and depends on where you study the patients. So if you go to the general wards, you will see the incidence of AKI about 17 to 20%. 5% of those would require kidney replacement therapy. If you go to the critical care, so mainly in the ICUs, you're gonna find more cases of acute kidney injury, maybe because of they are critical. So about 30 can go up to 50% of the cases do develop acute kidney injury, and about 12 to 15% of those will require kidney replacement therapy. Here we have some of the published studies from China, from the US, and from Europe, mainly the United Kingdom. We can see that the incidence of acute kidney injury is about 20%, unless you look at the ICU, you're gonna have more incidence of acute kidney injury. Renal replacement therapy, as I mentioned, about 10 to 20%, depends on which population you're looking at. The main thing is for the comorbidities, we can see that almost all studies, the main comorbidities were diabetes, hypertension, chronic kidney disease, and cardiovascular disease. These were the main risk factors that can tip patients to get acute kidney injury, in addition to the COVID-19. If we look at the earlier studies from between the US and China, so here we can see at the US that they had more or higher incidence of acute kidney injury in the dark blue bars, and the light blue bars are the patients who require renal replacement therapy. So we can see that the incidence is high, between 5 to 60% of acute kidney injury in comparison to China, which were much less. So there wasn't real conclusion, why is that happening? But maybe if we look at the comorbidities that we can see in the US, they had more patients to have diabetes, about 15 to 50% of the patients were diabetic, and also more hypertensive patients. 30 to 80% of the patients were hypertensive. If we compare them to the Chinese population, they are much less. So maybe that is why, at least in the US, the rate of acute kidney injury associated with COVID-19 was higher. If we take one of these studies, this is one of the earliest that was published in May 2020. This was done in New York. They studied patients in 13 hospitals in New York over 5 weeks, from March 1st to April 5th. They had about 5,450 patients. So they divided patients who developed acute kidney injury, who did not. About 37% developed acute kidney injury. Of those, they categorized them into acute kidney injury type 1, stage 1, stage 2, and stage 3. And those stages based on KDIGO guidelines. So stage 1, if you have a serum creatinine 1.5 to 1.9 times the baseline, or a rise of more than 26.5 micromole per liter. Stage 2, if you have a serum creatinine 2.9 times the baseline. Stage 3, if you have 3 times the baseline or more. So of those patients who developed the acute kidney injury, if we look at the comorbidities, we see again that diabetes and hypertension were more prevalent in the acute kidney injury group. So this was again a risk factor to get the AKI when you get COVID-19 infection. And we can see that the mortality among those who developed acute kidney injury is quite high, and it increases with the increased severity of the AKI. AKI stage 3 can have up to 50% mortality risk. So from this study, we had 37% of the patients who developed AKI, and about 14% of those required renal replacement therapy. About 90% of the patients who developed AKI, who were on mechanical ventilation, developed AKI. And those 50% of those where the AKI happened within 24 hours of intubation. So the sicker patient is the faster or rapid decline in kidney function happens. Risk factors for AKI included older age, diabetes, cardiovascular disease, black race, hypertension, and the need for ventilation and vasopressor medications. Unfortunately, the mortality rate is quite high. We can see that with the AKI group, 35% of the patients did die. Here, we looked at a study that studied only diabetic kidney disease patients. So they had diabetic patients, compared them to CKD patients. So diabetic with CKD or just CKD alone. They had about 2,000 CKD patients and about 740 diabetic kidney disease patients. Of those, about 1,000 got COVID-19 infection. In the CKD group, 400 patients in the diabetic kidney disease group got COVID-19 infection. If we look at the outcomes and what's the impact of COVID-19 on diabetic nephropathy patients, so we can see that patients who developed COVID-19 pneumonia, we had 88% more risk of developing the COVID-19 pneumonia in the diabetic kidney disease patients compared to CKD alone. So we have 16% in CKD and 30% of risk of developing COVID pneumonia in the diabetic kidney disease patients. Intubation rate is 100% higher, so 11 compared to 23%, and fatalities is 20% higher in the diabetic kidney disease patients. So those patients, diabetic kidney disease patients, have higher risk of developing the infection, higher risk of mortality as well. Another study looking at the AKI treated with renal replacement therapy in the critically ill patients with COVID-19. So here they look at the patients who were at risk of AKI. They had about 3,100 patients. Patients who did not develop who did not develop AKI or developed AKI but didn't require renal replacement therapy were about 2,400 patients. 1,400 patients did not develop AKI, and about 1,000 patients developed AKI, distributed equally among the three stages: AKI stage 1, 2, and 3. Those who developed AKI requiring renal replacement therapy were around 637 patients. We can see that among those 637 patients, 403 patients did die. So this is a high percentage of mortality, about 60%, and those in the critical care unit did have mortality. Of those, the 216 patients who were discharged home, we can see that the patients who did not require renal replacement therapy at discharge were 143 patients. 86 of them got complete renal recovery. 57 patients did have partial renal recovery. So still some patients did develop CKD post-COVID. And of those who were discharged requiring dialysis, so who were dialysis dependent, about 73 patients at 60 days, 69, most of them were alive. Of those who were alive at 2 months, about half of them, or a bit more than that, 39 patients, were dialysis dependent. So those patients who did have acute kidney injury, who got COVID-19 infection, and it was severe enough to let them go into the ICU, did end up, if they survive, to be dialysis dependent at the end or after 2 months. So this again shows how aggressive the disease can be in certain population. If we look at the comorbidities of those patients, again, we see that diabetes and hypertension were prevalent among those patients. And here we can see that 70% of the patients were having, or they entered without any kidney problems. So the eGFR was above 60 ml per minute. So again, showing how aggressive the disease can be in certain population with certain risk factors. If we look at the AKI 28-day mortality, we can see it increases with age. The black bars are patients who had AKI requiring renal replacement therapy. And for the comorbidities, we can see that smoking, hypertension, diabetes, cardiac disease as well were among the risk factors in getting this 28-day mortality risk. Now, what is the potential mechanism of AKI? Dr. Bassam mentioned some of them on the heart, but essentially we have either the direct invasion of the virus particles to the kidneys. In some studies, they found post-mortem biopsies. They found the viral particles in the glomeruli or the tubules of some of the patients, but other studies did not show that. Even they had the post-mortem biopsies, they didn't see any evidence of direct viral invasion at the kidneys. So we don't know really if there is direct invasion, but most of the biopsies would show ATN as the main cause of the acute kidney injury. We have other mechanisms, the prerenal, because of the hypotension. We have the cardiorenal syndrome. Weak heart will lead to weak kidneys. We had the cytokine storm. Again, this will cause hypotension and acute tubular necrosis. We have the endothelial dysfunction causing hypercoagulability and kidney infarction, leading to acute kidney injury. And we have the sepsis by itself and getting probably secondary bacterial infection, and patients who might develop acute interstitial nephritis due to the antimicrobials or the antiviral therapies. So all these are potential mechanisms of developing acute kidney injury in COVID-19 infection. What about dialysis patients? Dialysis patients, from different studies, we can see that the incidence of developing or getting COVID-19 infection is between 10 to 20%. And the mortality rate, unfortunately, is quite high. It can be between 15 to 30% of mortality rate. And diabetes is, again, prevalent in those patients who get higher mortality rates. So now we go to the glomerular disease. As I said earlier, patients who were already diagnosed to have, for example, lupus nephritis, ANCA vasculitis, on immune suppression, what shall we do with those? Shall we continue with immune suppression? Shall we stop it? And those patients who present with new presentation of vasculitis or lupus nephritis, shall we go ahead and admit them to the hospital, increase the risk of getting the infection, do the kidney biopsy? Shall we induce therapy with heavy immune suppression, give them the pulse steroids or the IV cytotoxic agents? All these were questions, and we didn't have an answer to, but there was a consensus after like 2 or 3 months from the pandemic, and this is summarized here from the Columbia group in New York. So they, with regards to the immune suppression for glomerular diseases, they recommended, so these are not guidelines, but just a consensus, that to discontinue the antimetabolites for patients with confirmed or suspected infection, mainly the Cellcept or the mycophenolate and azathioprine. Consider the discontinuation of the antimetabolites in patients who have sustained remission more than 12 months. And they were in favor of short-acting reversible agents over long-acting infusions. So if we can have oral, for example, cyclophosphamide better than IV cyclophosphamide, in case the patient developed COVID-19, we might have some control over the immune suppression at that point. Avoid therapy initiation for marginal criteria or non-standard indications. Avoid therapy initiation for minimally symptomatic patients with stable EGFR, etc. For diagnosis and monitoring, reserve biopsies for critical decision-making needs, so not to admit everybody and get the biopsy done. You have to be selective and try to treat empirically without a biopsy if the condition is obvious. If you have, for example, low complements and anti-double-strand DNA, probably this hinting at lupus. If we have the anti-PLA2R antibodies positive, probably this is a membranous nephropathy, so you can treat accordingly and try to delay or avoid admitting the patient to the hospital unnecessarily during that first few months of the pandemic. For the supportive care, we should continue with the ACE inhibitors or ARBs in the absence of clear contraindication at that point, because there was this theory that Dr. Bassam mentioned. ACE receptors facilitate the entry of the viral particles, but some studies didn't show any effect if you stop or continue the medication, mainly the ACE or ARB inhibitors. It wouldn't make a difference in terms of getting the infection or in terms of the outcomes. We should continue prophylactic antibiotics. We should encourage social distancing and encourage use of the masks outside of the house. And of course, to complete the recommended vaccinations, mainly the influenza and pneumococcus. With regards to the infusion therapies, this was another challenging issue because we have patients who would get their monthly IV cyclophosphamide or their monthly IV rituximab. So at that point, it was deemed logical to postpone all non-essential infusions. If the patient is stable enough and you can delay the treatment, you would do that, or at least adjust the schedule so that waiting rooms and infusion suites allow for social distancing and avoid crowding, make the patients wear the face mask, and try to be as protective as possible.
Sorry, Dr. Enes, you have 5 minutes.
Okay, almost done there. With regards now to the dialysis, as I mentioned, dialysis units, patients are going there 3 times a week, 4 hours each time. So they spend lots of time in this closed unit with the healthcare staff, the nurses. So they have a high risk of developing or getting the infection. So in Kuwait, what we did was we had like a triage at the entrance of the dialysis centers, which is roughly what's been done around the world as well. So we had nurses at the door checking patients, checking their temperature, asking about any symptoms. So if patients have any respiratory symptoms, diarrhea, if they have contact with positive cases, if they have travel history back last year, those patients will be better to be isolated, or they get dialysis in a separate bed or a separate room, not to be in the main room with other patients. During the session, check the temperature again, make sure the patient is wearing masks, no companions with the patient, and to minimize crowding in the waiting areas. And healthcare staff were advised to wear full PPE since we had, I would say, quite common. We have asymptomatic patients, asymptomatic dialysis patients with COVID-19 infection. And after the session, if the patient is asymptomatic, they can go home. Preferably, they each go by himself and avoid grouping, avoid going in the same car or public transport. If the patient is suspected to have COVID-19, patient was advised to go to the ER and get the swab done. So this is in line what's been happening around the world. Same thing, if you have suspected cases, you have to do all what I mentioned earlier in terms of separation of the patients and triaging them in order to avoid any outbreak in the dialysis unit. We have roughly 100 patients coming in daily in the dialysis unit at different shifts. So you don't want to have an outbreak there, because this will mean a catastrophe. So if we have suspected cases, if they are asymptomatic, we will follow them closely. If they have rest symptoms or fever, then better they be admitted and get dialysis in an isolation room. If the patient's COVID positive in our group, we were admitting them to the hospital till they get cleared. So at the old protocol, we needed an exit swab, but now we have the 10 versus 20 days, depends on the severity of the presentation. For those who came last year, the return travelers, we had a designated center for those patients. They have to be, because they have to be like an institutional quarantine. So we had them admitted for 2 weeks. They were getting dialysis inside the hospital for those 2 weeks, and then went home, get another quarantine for another 2 weeks. So a total of 1 month. All those patients were COVID negative patients. Lastly, there was a call to action with regards to the COVID vaccine. Now, because as I mentioned earlier, that dialysis patients, they can get the infection easily because of the surroundings. So they are going 3 times a week, 3 to 4 hours with high exposure to many other patients and staff. And there is high risk of infection compared to the general population, 50 to 20 times from different population, different studies, and the case fatality rate is quite high, 16 to 32%, and the mortality risk for the in-center hemodialysis population compared to the general population is very high. So there was a high demand that those patients, dialysis patients, need to get the priority to get the vaccine. In other words, in like for North America or Europe, they were categorizing patients who should get the vaccine, which group, and this from the International Society of Nephrology, they were demanding or asking all the countries to prioritize dialysis patients to get the vaccine and be top priority, because this would reduce mortality, this would reduce the infection, and would reduce the healthcare burden. So some take-home messages: COVID-19 associated acute kidney injury is common with high risk of morbidity and mortality. Hypertension, chronic kidney disease, diabetes are the main risk factors. Management of glomerular diseases in COVID-19 era had to be modified. In-center dialysis carries high risk, high COVID-19 infection risk. COVID-19 vaccination seems to help the community in general and dialysis patients in particular, and is highly advisable. With that, I conclude. Thank you, and be happy to receive any questions.
Thank you, Dr. Anas. It was a very informative lecture. There are actually quite a few questions. We'll try to take some. A lot of questions on the safety of COVID vaccination in dialysis patients, and you have mentioned that already. There's a question on should patients who had glomerular nephritis on treatment receive the COVID vaccine?
Yes, so we go with the general guidelines, even from the Kuwait protocol. So if their disease is quiescent, so they are stable with their disease, they're not in active relapse, or do not have any sort of infections, and they're stable on their immune suppressive therapy, their prednisone dose is less than 20 milligram per day, then yes, they can take the vaccine.
Similarly, there's another question about patients with autoimmune disease receiving biological agents like rituximab. Is the vaccine safe in these patients?
Yeah, so with rituximab, it was initially a bit vague and probably still is. The recommendation is that those patients should get COVID vaccine prior to their dose of rituximab dose and wait at least 4 weeks to get their rituximab dose. Initially, we were saying we should wait for like 3-4 months till you get the rituximab. Till you get the vaccine after rituximab. But now we, from Kuwait protocol, the British and even the American rheumatology guidelines, I believe 4 to 8 weeks post rituximab, it is safe that you get the COVID vaccine.
Okay, there's one more question about this. What is the most suitable vaccine in kidney transplanted patients?
Well, there haven't been any studies with regards to any vaccine. I believe any vaccine available should do, especially I think you asked about the transplant patients. So same thing, if their immune suppression is stable, their prednisone dose is less than 20 milligrams, they can take any vaccine available. There hasn't been any issues because these vaccines are not like live virus vaccines, so they can take any vaccine.
Okay, Dr. Anas, one last question. There's a question about do patients undergoing dialysis will have the same benefit of the vaccine as a healthy person? She's comparing herself to her mother who is under dialysis, and after a couple of weeks, she had no antibodies at all, whereas the healthy person had a high level of antibodies.
Yeah, that's an excellent question, actually. Nobody knows. And we are studying that currently in Kuwait in our dialysis patients. Yes, you are right. Some patients might not develop the antibodies. We see it actually in our dialysis patients. We vaccinate them against hepatitis B, and some of them never respond even after booster doses. So now we are testing it on COVID-19 vaccine as well. But actually, nobody knows the answer.
Okay, thank you so much, Dr. Anas, and it was a pleasure having you.
Thank you very much.
We move to the next. Dr. Ali Dai is a consultant rheumatologist at Amiri Hospital, and he will speak about the anti-inflammatory medications for COVID-19. So welcome, Dr. Ali.
Thank you, Dr. Mariam. Thanks to our hospital, Amiri, and the organizing committee for such opportunity. I wish my slides are clear, and I will give some information to share with you. I would like to pray for all the souls that's been lost during the COVID-19, especially those in the healthcare workers. So in the next few minutes, I will speak about the anti-inflammatory medication in the era of COVID-19. Those are my disclosures. So the objective is to take an overview on the immune system, the pathogenesis of the COVID-19, and how does your body react to it, and the cytokine storm, take it in some details with some therapeutic option which has been used. As you know, one part of your body, the body consists of multiple systems, a GI system, urinary system, cardiovascular system, and the immune system, which the role for it is to protect you from the enemies that comes inside your body, either COVID-19 or other bugs. What's been proven so far to prevent this disease or to treat this disease is the prevention. So wearing your face mask, social distancing, take care of yourself, those are the international standard that we are advising ourselves, our beloved family, and our patient as well. Three more important issues in our patient is one, to control their inflammation. If a patient has an inflammatory condition, either rheumatoid arthritis, gout, or any other condition that it has an inflammatory component, we need to suppress this inflammation as much as possible to give the body or to give the immune system more power and more time to fight the COVID-19 virus. Also, to control your disease. If you have other comorbidities, not merely the inflammatory diseases, if you're having a cardiovascular disease, if you have a diabetes, if you have a chronic kidney disease, thyroid issue, controlling such comorbidities also important to enhance the efficacy of your immune system. And after that, if you control your inflammation, you control the other diseases that you have, taking your medication into consideration, it's an important issue, because if you have something that acts on the immune system, for example, high dose steroid or a biological agent, it may reduce the enhancement of the immune system in a certain way. Vaccination is now the only I'm not saying this is the first thing that you should do. There are many things to prevent the COVID-19, but what I advise myself, my family, my patient, if you take the vaccine, it is the easiest way to prevent your disease. This is the thing that you're having in your hands. I always put an example for the patient when they come to our clinic. So then listen, you come to me through car, and when you're driving, the first safety measure that you use is your seat belt. Now, in this year, 2021, the first thing that you do to protect your life and yourself is to take the vaccine, which is available in our country. So now let's go through the immune system. So the immune system, it's made of many components. It could be a barrier for the body, like that, and the lymphatic system, thymus gland, skin, spleen, the hardware side, shall I say it, on my left side of the slide, and the immune system itself, it divided into two ways: innate immune system, and acquired. The innate, which is a physical barriers, and the blood-borne phagocytic first line soldiers, shall I say, and the acquired one, which has been divided into T cell immunity and a B cell immunity, and through that immune system you protect your body. So basically, if the virus SARS-CoV-2 comes inside your body, the only good thing that you do is to prevent the virus when it comes, But unfortunately, if the virus comes in, your immune system is starting to fight it until you resolve. So far, what medication has been used to from an auto-inflammatory way to enhance the immune system to react to the virus itself. Hydroxychloroquine, which is one of the disease-modifying medication that we use in rheumatoid arthritis and systemic lupus erythematosus, it's been also been used in malaria. In 2020, the first line treatment was there, and the idea for that is to prevent the virus from replication and causing problems in the body. Also, it has been used as an anti-inflammatory based on a theoretical matters, but unfortunately, it doesn't reduce mortality. It doesn't alter the patient that require ventilation. Also, it increased the risk in some patients from the COVID-19 problem. There are some reports for the arrhythmia. So from a recent Cochrane review published in March 2021, over 14 total study included, and it showed that hydroxychloroquine does not reduce death and probably does not alter the number of patients required ventilation, and it causes adverse event. So hydroxychloroquine, it was taken and withdrawn from most of the guidelines, and I believe Dr. Al-Hasawi will speak more about the Kuwaiti guideline. Another thing is vitamin D. As a rheumatologist or as an internist, we link vitamin D as an association for most of our medical conditions. For example, any medical condition, we would like to eliminate that vitamin D deficiency plays a role in it. So vitamin D, does it help the immune system? Yes. Theoretically, the vitamin D levels, if they are high, they enhance the adaptive immunity in form of decreasing Th1 peripheral cytokines, and also to increase Th2 cytokines, which has an anti-inflammatory way on the immune system. It enhances your or boosts your immunity. The role of vitamin D in the COVID-19, there is a systematic review and a meta-analysis of 23 studies containing 11,901 participants. They found that COVID-19 patients who were suffering from vitamin D deficiency or insufficiency, they also about 3 times having the chance of getting the infection, and also 5 times higher probability of developing a severe disease. So what I advise people to as a preventive measure to have a good vitamin D levels, because it's been proven that it enhances the immune system in such way. I know people, maybe they will go for alternative or food or diet to enhance their immunity. We encourage that to use a non-pharmacological way, but the only proven pharmacological is the vitamin D levels. So what happens if the virus come to your body and started to cause a problem? The serious problem that we do is mortality, and we would like to prevent that. Cytokine storm, meaning that if the virus comes inside your body, your immune system is starting to reacting in a crazy way that it causes problem to multiple systems. For example, it can cause constitutional symptoms like fever, arthalgia. It can cause nervous system complications. It can cause heart problem. It can cause lung problem, ARDS, difficulty ventilating, and I believe our ICU team at that stage, at this stage, they are expert now in different hospitals across Kuwait: liver, kidney, vascular, endothelial, skin, multiple system. They're trying to react, hypercoagulable state, put a sequence of event which as a physician or a treating doctor, we don't like to have. So what happening if the cytokine storm is there? So if the cytokine, So if the if the virus comes in, what happens? How do we understand the cytokine storm? Usually, we take the clinical aspect to our scientists, and the scientists usually they will give you the plan of the immune system. How does the virus act, or how does the disease pathogenesis is there, and what is the best action shall we take from a theoretical then in the clinical aspect. So if a virus comes in, cytokine storm is there. There were multiple lines of treatment, or there are multiple ways of getting the immune system to act differently. Is it interleukin 18? Is it interleukin 1, anti-TNF? Those maps, those lines, or those, shall I say, corridors, the immune system need to be blocked in certain agents that may help us in salvage our patient. So in a real life situation, when do you suspect cytokine storm? If there is some clinical features like persisting fever doesn't go down, if the laboratory investigation showed some cytopenia, low hemoglobin, low platelet, low neutrophils. Also, if you think about patient who having organomegaly, like splenomegaly, hepatomegaly, altering mental status, limb weakness, palsies, coma, acute kidney injury, picture of ARDS. Other labs which are important, the ferritin level, if they are sky high, doubling or tripling or more than 600. ESR, which is an acute fate reactance as well, it is a good inflammatory marker. Triglyceride, increase serum soluble interleukin 2R and interleukin 6 maybe is not available across all the hospitals. Maybe they use it for research purposes. High D-dimers, high lactic dehydrogenase, and low fibrinogen. It also those parameters puts you in a risk of developing, or it puts you in high suspicion of developing cytokine storm. So what is the best way to assess the patient if they are having a cytokine storm is to do the H score, which is basically a score that it has multiple variable, and in each variable there is it weighted by a point. Variables are temperature, organomegaly, cytopenia, triglyceride, fibrinogen, ferritin, AST, and hemophagocytosis on bone marrow biopsy, and if the patient is already known on immunosuppressant. We took the H score from our literature of dealing of autoinflammatory conditions, and also dealing with a patient who has some autoimmune connective tissue disease like lupus. If the H score is high, meaning more than 169, corresponding to a sensitivity of 93% and specificity of 86%. So how do we deal with our patient? As I see, this is my philosophy of dealing with every patient I see every time in a clinic. I go to the science, I go to the knowledge that I have, that I studied during my medical school, the journals, whatever I have in the book. Then I would like to have some experience. I'd like to know each patient. How do I tackle them? Sometimes my decisions will be based on an opinion. At the end of the day, I need to individualize and practice personalized medicine, where I treat each patient differently, meaning I will use the best medicine for them to try to help them and to prevent any damage. Just to cross for our medical history, Nobel Prize was given in physiology or in medicine in 1950 for those great three scientists for the invention of hormone, which is corticosteroid. So steroid has been we used steroid for more than 70 years now, and in the recent guideline, especially locally and internationally, it has been also FDA approved therapy for treating patients with COVID-19 infection, but not all of them, just specific patient who has or who required oxygen or who required a ventilation. And the first study, which is published, which is done in the UK, across British hospital, the recovery study, they found that dexamethasone reduced the death by 1/3 of the ventilated patient. Subsequently, in the literature, meta-analysis of data of 7 randomized controlled trial showed also it lowers the 28 days of mortality of that patient. Another meta-analysis showed benefit effect for patient required a mechanical ventilation. So steroid, which are immunosuppressive therapy, we would like to give them as least as possible, as short as possible, to get the benefit from it and to reduce the side effect. What happens if the patient is diabetes? It's been published recently in the Diabetic Journal in October 2020. How do we manage patients with hyperglycemia with COVID-19 inflammatory storm? And I believe my colleagues endocrinologists or the diabetologists have more experience than me dealing with such entity. What's happening with tocilizumab? Tocilizumab is one of the drug. It has been approved for rheumatoid arthritis. We use it for vasculitis as well. It is an interleukin-6 receptor combinant monoclonal antibody. The indication to give it for patient for COVID-19, especially if you suspect or if patient high risk to develop the cytokine storm, if they have high interleukin-6 level, if they have high ferritin, if they have high CRP, which is doubling over the next 24 hours, if her ferritin is high, if you suspect their patient are ongoing cytokine storm. The initial dose is 8 milligram per kg, and you can repeat the dose 12 hours apart. There are some basic lab you should do for the patient that try to avoid in liver impairment and patient who you think they have an active TB or a hepatitis. So the idea of blocking interleukin-6 is to suppress the immune system in one way that you suppress the subsequent inflammation and to help the immune system to reconstitute itself and to get a better outcome. It has been multiple study for tocilizumab, and most of them they are conflicting evidence over the last, shall I say, year and a half, but a recent meta-analysis which been published a couple weeks ago about interleukin-17 in COVID-19 in UK. So this is a forest plot for the 28 days mortality across the intervention, where are multiple studies. Those studies, they are global and locally. Different results was them, and the idea for doing that meta-analysis is to prove that interleukin-6 inhibitor, as we use it, Actemra or tocilizumab in Kuwait, because there is another interleukin-6 sirolimus it's been using in the States and another countries, but the studies was done on the tocilizumab itself, Actemra, and it showed a good the majority of the study reported mortality rate less and some benefit from using that drug. Another comparison for the incidence rate of mortality over the 28 days, the combination of the intervention arm, which each arm also showed a good data comparing for the 4 global studies and one in Italy, France, Brazil, and the United Kingdom. So from the different multiple randomized controlled trials for tocilizumab, interleukin-1 associated with a meaningful improvement in the outcome for the patient, but the long-term benefit and the efficacy for the healthcare is not being assessed yet. So there is a conflicting data regarding interleukin-6, but it's been helpful for patients to get them through the cytokine storm and to prevent mortality in 28 days. What about other immunosuppressive therapy? Interleukin-1 anakinra, which has been also a monoclonal antibody. They're considered in patients who has contraindication to tocilizumab. It is a subcutaneous injection. We use it for auto-inflammatory diseases. We used to use it in rheumatoid arthritis. It's subcutaneous. You can give it twicely for the 72 hours, then you can repeat it after 7 days. It needs some adjustment for kidney impairment and dialysis. The idea of that, it was studied in a non-randomized trial, and it showed some benefit for patient who's been on ventilator and in the cytochrome storm, but not that severe. Another drug was being used and approved in rheumatoid arthritis, which is a JAK inhibitor, JAK kinase. It's another way of dealing with the auto-inflammatory conditions. JAK kinase, it can link to the membrane receptors and activate transcription of STAT protein. It is a selective JAK1 and JAK2. What we use it is called baricitinib, because there are two other JAK inhibitors. But baricitinib, which is Olumiant, it has been studied in the adaptive COVID-19 treatment trial 2, which has been combined to remdesivir. And the idea is to try to suppress the virus replication and the subsequent immune reaction in the body. Based on the ACTT trial data and the emergency authorization by the FDA, it approved for using combination baricitinib and remdesivir. However, it doesn't show a clinical trial that it will be benefit from the mortality. Still, the best evidence so far in our autoimmune disease, autoimmune or anti-inflammatory conditions is the use of a steroid and dexamethasone. Another old drug that we use, which is a cheap drug, not that expensive compared to the previous one I mentioned, is colchicine. Colchicine has been used in gout before. It's been used in Behçet disease. It's been used in aphthous ulcer. It's been used recently in the cardiovascular prevention as well. Now, there is an open label randomized multicentric to low dose colchicine as an anti-inflammatory. It's been enrolled also. The idea of giving an anti-inflammatory is to tackle the immune system in such way to prevent the consequences of the inflammation of the SARS-CoV-2. The colchicine coronavirus, corona, it is a phase 3 double-blinded placebo-controlled trial, which showed some benefit over the next 30 days. I guess I went through the immune system, the adaptive system. The best way is to prevent the virus to your body. How to deal with the inflammation is important, and how do you understand the inflammatory way of, or how does the immune system react to your body? Trying to suppress those inflammatory markers by various medication is important.
Thank you very much, Dr. Ali, for this very informative lecture. We have a few questions for you.
Sure.
The first question is, what should be the dose of vitamin D for COVID-19 patients?
So the idea is before you get the COVID-19, we need to enhance the vitamin D level in our population based on your lab. We'd like to have it in most of our labs, especially in Amiri, to have it more than 75 value. So basically replacing your vitamin D is important. If the patient having vitamin D deficiency, we would like to replace it as quickly as possible, usually by giving them 50,000 international units weekly for 8 to 12 weeks, then to continue on their daily requirement. But using vitamin D as an anti-inflammatory, it didn't show a benefit on the spot. So if I'm having COVID-19, I give it and I hope for the best. I try to tackle normal population so their immune system will be ready and to eliminate or to reduce the factor of vitamin D deficiency in their body.
Okay. The second question is, does vaccine cause cytokine storm like viral infections?
Well, to take when I've been asking about vaccine, I will answer in two parts. One, the safety and the efficacy. So the safety, it's been there so far. The vaccine which been used, whatever brand is there, it didn't show any side effect in the immune system. For example, enhancing the autoinflammation or enhancing the disease itself. Some side effect, which is a myalgia, site reaction, it takes a couple of days to resolve. So that from the safety, it's been safe. It didn't precipitate cytokine storm. From the efficacy, also the efficacy, there are some factors to enhance the efficacy, but I'm not aware about any data that's been someone who took the vaccine and the vaccine led to a cytokine storm or an autoinflammatory condition. It's not a mimicker of our diseases.
Okay, one last question. Do you recommend early or late intubation for patients on high flow oxygen?
I guess the intensivists, they are having better experience than I am. I wish I don't intubate any patients, but what I have a limited experience during dealing with COVID patients, that it's a clinical judgment. Delaying intubation as much as possible is better, but I believe the intensivists, they have the better answer.
Okay, thank you very much, Dr. Ali.
You're welcome. Thank you.
Now, speaker, Dr. Al-Munder Al-Hasawi. He is a consultant in internal medicine and infectious disease and genitourinary system at the Infectious Disease Hospital. And he was talking about the latest guidelines in COVID management. So welcome, Al-Munder.
Thank you, Dr. Mariam. You can see the slides?
I can see the slides, yeah.
We can't see the video of Dr. Muntar.
Your voice is not clear. Okay.
Can you on the video, sir?
Yeah, I'm trying just a minute.
Okay.
Can you see me now?
We can see you and we can see the slide.
Okay. Excellent. So I can start now?
Yes, you can. Yeah.
Yeah, okay. Yeah, thank you so much. And thank you for giving me the opportunity to talk about the latest guidelines in COVID management. So during this presentation, I will talk briefly about the current practice in COVID management of adults in Kuwait. I will highlight the COVID stages and the current therapeutics. Then I will try to compare our treatment protocol with the international guidelines from WHO, IDSA, and the NIH. If there is time, I will mention a few of the clinical trials. At the beginning of the epidemic or the pandemic, we all thought that COVID-19 is a respiratory virus, but apparently with the time, it became very clear it is a multi-system virus. It can affect, I can say, any part or any organ of your body. And there are a lot of extrapulmonary manifestations of this virus. It has dermatological, I'm sure you have been across a lot of these cases, like petechia, urticaria, erythema, vesicles, also cardiac. It was already covered by Dr. Bassam Al-Banat. Endocrine, which might be the whole or the most important topic that is being covered by this webinar or symposium. It can cause both hyperglycemia and diabetic ketoacidosis, and also the therapeutics itself can cause the same, the hyperglycemia and DKA. Gastrointestinal was quite very common presentation we are seeing at the older strains. Neurological manifestation, plenty of them. Thromboembolic, I'm sure every one of us has been cross one or more cases with some thromboembolic event from COVID. Hepatic and renal, also a very common manifestation of COVID-19. Unfortunately, so far, we don't have any drug that appear to be highly potent or a game changer. Even the remdesivir, the antiviral, even the dexamethasone, nothing really highly potent. I can say we failed, or the scientists failed to reach for a treatment for COVID-19, although they have a very good success on prevention of COVID-19 through the vaccine and soon through the pre-exposure prophylaxis antibodies. So if you want to talk about therapeutics of COVID, we have to answer the question, which stage is my patient is on stage, or he's on the pulmonary or the hyperinflammation phase? Because the therapeutics that you will select in each stage is quite different. So someone with a recent diagnosis, a few days from symptoms onset, with high-grade fever, with dry cough, and you might find a low lymphocyte on CBC, this might suggest that your patient on the viral response stage. And you, at this stage, you have to consider the antivirals to stop the viral or to block the viral replication. However, if you have someone who start to develop shortness of X-ray or chest imaging with high transaminitis, high transaminases or transaminitis with no low or normal prolactin, then you might consider that we already start the pulmonary phase. Once you go further and the immune response of the body triggered, you might go into the as high inflammatory marker like CRP, LDH, interleukin-6, D-dimer, ferritin, troponin, pro-BNP, and others. And it's very important to differentiate between the two, because you don't want to give your patient an immunomodulator while he's on viral replication phase. This might make things worse. And antiviral, if you believe that he's out of the viremic stage. So honestly, I think every patient should be treated individually. There's no guideline for every patient. So there are several therapeutics. I can divide them to three classes: the antiviral, the passive immunization, and the immunomodulator. And Dr. Ali made my job easy by covering all the immunomodulators. So for the antiviral, there are several investigational drugs like the baloxavir and the favipiravir, the Avigan, the chloroquine or hydroxychloroquine, the interferon, and others. And then we have the passive immunization like the convalescent plasma or monoclonal antibodies or hyperimmunoglobulin. Then we have the immunomodulator like steroid or interleukin-1 inhibitor, anakinra or interleukin-6 inhibitor, tocilizumab, and JAK inhibitor, baricitinib, and others. So there are several clinical trials are ongoing all over the world trying to investigate many of these therapeutics. And if you notice on this slide, at the beginning of pandemic, most of the studies were from China. But with the time, we are getting more data from USA and from European Union. Kuwait was part of this. And I think during COVID era, we had a very successful new generation of research in Kuwait. The Ministry of Health approved more than 170 clinical trials during the 2020. Most of them are related to COVID-19 investigation and therapeutics. And some of these studies are very well designed with a high standard. And I'm sure once they are published, they will have a good impact on science. And some of them, like the favipiravir, the Avigan, might be considered as a cornerstone for any future recommendation with or against this drug. Also, Kuwait participated on the WHO Solidarity Trial, which is a multinational trial investigating many therapeutics like the Calitra, like the chloroquine, remdesivir, and data were published, and another set of data also is being collected and will be published soon, hopefully the next month. So before I mention the Ministry of Health clinical practice guideline for management of adults with COVID-19, I would like to highlight the clinical status ordinal scale, which is a very widely accepted scale for clinical improvement, because most of our talk now will focus on certain categories. So it is a scale from 1 to 8. 1 is someone at home, not hospitalized, without any limitation of activities. Then you go for 3 and 4, hospitalized patient, patient on oxygen, patient on high flow oxygen, patient on mechanical, very important in order to evaluate the effectiveness of each drug. So let's look at the Ministry of Health guideline for management of COVID-19. I know it looks like quite outdated, but initially there was an ID task force protocols from 1 to 8, version 1 to version 8. But then, as the COVID apparently was a multi-system disease, there was a task force from all specialties, all the internal medicine specialties. And they prepared a very nice guideline, over 107. It was involved with more than 40 expert members and guests from different specialties, and they came out with this guideline. Most of the data is still very valid, and I think some of the information only need to be updated because it's an ongoing process, ongoing. So in summary, the MOH protocol emphasizes on 4 therapeutics for every patient, which are the anticoagulant, antibiotics, corticosteroid, and the antiviral. Then we have the controversial part. The protocol gives you an option to use the following 3 therapeutics on certain cases, which are the convalescent plasma, tocilizumab, and anakinra. And I don't think tocilizumab is any more controversial issue after the recent data we get from the meta-analysis and from the recovery trial, but we might argue with the convalescent plasma and the anakinra. So I will mention briefly each of these therapeutics.
Dr. Munta, very sorry to interrupt.
The NIH, FDA,
your voice is
yes,
having a lot of breaks in between.
Okay. You can hear me?
Yeah, we can hear, but there is a lot of lag in between. Every sentence has a lot of lags in between.
Oh my God, yeah. What do you suggest?
Are you connected to mobile data or Wi-Fi?
Let me connect to the. Okay, this is the Wi-Fi. Which one is
now
better?
It's better. It's much better. Thank you. Thank you very much.
Yeah, thank you. Yeah. So I'll go through the therapeutics and compare it with the internal guideline regarding each item. For the anticoagulant, the Ministry of Health protocol advised for no anticoagulant for non-hospitalization unless the patient is in a high-risk group. For hospitalized, they divide them to mild to moderate they will get prophylaxis dose. Then we have the severe and critical. You might consider on severe prophylactic or intermediate dose. And I know this is quite unusual term to use, intermediate dose, in most of the guidelines. And also on the critical, they want to consider the dose. For post-discharge, also they recommend for anticoagulant for high-risk group for 14 to 45 days. If we want to compare this with the NIH data, they don't recommend anticoagulant for unhospitalized patient. So we shouldn't initiate anticoagulant or antiplatelet therapy to prevent thromboembolic or arterial thrombosis unless other indication exists. Someone with rapid deterioration with pulmonary or cardiac or neurological function with localized or loss of peripheral perfusion, you have to consider the anticoagulant. Otherwise, you have to use the prophylaxis dose. For hospitalized patient, there's insufficient data to recommend either for or against the use of thrombolytic or higher than the prophylaxis dose. So really, they are very strict about using the prophylaxis dose rather than the therapeutic dose. However, they mentioned recently on a press release, which hasn't been published yet, that there is ongoing data on 300 hospitals all over the world that might suggest using a therapeutic dose have an effect on moderately ill patient or hospitalized patient in terms of mortality and outcome. So we are waiting for this data in order to have a more clear answer which dose works for the patient, if it's the prophylaxis dose or the therapeutic dose. For the antibiotics, the MOH guideline divided into 3 categories. For uncomplicated, they don't need antibiotics. For mild to moderate, you have to start with ceftriaxone plus azithromycin or doxycycline. And if the patient is necessary, you can go for multifloxacin or levofloxacin. Then you have the severe cases. Most of the misuse of antibiotics that is going on now on the uncomplicated category, because we noticed that most of the COVID patients who go to the primary care, they will get antibiotics although they have mild disease and no evidence of secondary bacterial infection. So honestly, we have to use it wisely. And also, most of the patients are in casualty or being admitted to the hospital, they will start the antibiotics immediately, which is against the current effort in Kuwait. And the other thing, you are adding more harm for your patient by exposing him for a more toxic therapeutics. So unless you have clear evidence, someone with the productive cuff, greenish, yellowish, acceleration, rapid deterioration, consolidation on the X-ray, someone with high PCT, leukocytosis with a neutrophilia, other than this, we have honestly to consider shouldn't we start antibiotics unless we have suspicion or confirmation that our patient might have a secondary bacterial infection. For the NIH, they recommend the same, and they advise to administer antibiotics within 1 hour of suspicion, and also to assess daily for de-escalation. For corticosteroid, this slide has been shared by Dr. Ali. We are quite liberal on the choice of corticosteroid. So the guidelines include dexamethasone, hydrocortisone, methylprednisolone, and prednisone. So, but if we want to compare it with the current recommendation from IDSA, and they always recommend the dexamethasone. And the only scenario that you have to move from dexamethasone to other type of steroids or corticosteroids is dexamethasone is not available. It can be administered either IV or orally, 6 milligram, once daily, and the FDA contraindicate steroid if you have fungal infection. Also, we have to be aware When we use steroid, it can cause elevation of blood pressure, as you all know, hyperglycemia, left ventricular free wall rupture in a patient with recent MI, immunocortical insufficiency. It can increase the susceptibility to infection, cataract, glaucoma, and possible damage to the optic nerve. Also, if you have someone who might have a disseminated steroid in the endemic area, you have to consider adding some antiparasitic drug.
والحين بتزوج عليها دكتورة لبنانية تشتغل معاه ويقول لها هي تفهمني انت يعني مستواك مو من مستواي.
Dr. Muntari, if you can off your video, I think this will help better in streaming the voice.
تقول حق سارة محمد يكتب نص البيت باسمك حطي بالك.
Is it okay now?
Yeah, I think this will stream the voice better.
Somebody's talking by. Could you please mute your microphone, please?
What about remdesivir? We have a good experience here in Kuwait with remdesivir. It is an antiviral drug and is recommended for hospitalized patients who require supplement oxygen. It works very well on people with low flow oxygen. However, it has a very limited role on people who are on non-invasive ventilation, mechanical ventilator, or ECMO. Even they did recently a meta-analysis and they found it might affect the mortality, although the data suggests that it only reduces the rate of hospitalization, and also it can improve the clinical outcome, but it doesn't affect the mortality. However, if you break down the data, you might include all the current studies, you might find an effect on mortality if you use it on a patient who are on low flow oxygen. The dose is 200 milligram once on the first day, loading dose, followed by 100 milligram once day for 5 days. And in a patient with mechanical ventilator or ECMO, you might extend for 10 days. The remdesivir, initially it was not approved by FDA. It was under emergency authorization. However, in October, they approved it for treatment of COVID-19 on hospitalized adults and pediatrics more than 12 years. And after that, the FDA issued emergency use authorization for pediatrics less than 12 years. So now you have approval for adult and above 12, and you have emergency use authorization for above 12. What about convergent plasma? Although the guideline at Ministry of Health gave us an option to use convergent plasma, most of the international guidelines honestly are against use of convergent plasma because there is insufficient data to recommend either for or against the use of convalescent plasma in a patient with COVID-19. And the Ministry of Health might consider convalescent plasma for patients at severe COVID or life-threatening COVID or at risk of severe or life-threatening COVID, like someone with dyspnea, tachypnea, low saturation, respiratory failure, septic shock, multi-organ failure. You might transfuse 200 cc at any time, and the earlier you start, the better outcome. Although we don't have sufficient data, the NIH believe that the serious adverse reaction are infrequent and consistent with the risk associated with the plasma infusion or other indications. For the common side effect of convalescent plasma, transmitted infection is very unlikely nowadays. However, your patient might get allergic or anaphylactic reaction, hemolytic reaction, febrile, non-hemolytic reaction, transfusion-associated acute lung injury, or circulatory overload, or hypothermia, or metabolic complication, or post-transfusion purpura. I'd like to highlight here that convalescent plasma has an emergency use authorization till now. And the FDA approved it for 2 categories. high titer convalescent plasma, high titer of antibodies, and for hospitalized patient early in the disease course, or someone with impaired humoral immunity and cannot produce adequate antibody response. And despite the current emergency use authorization, most recent data indicate that there is no beneficial effect. What about tocilizumab? It was already covered by Dr. Ali. It is part of the MOH guideline. You can use it when you feel that your patient is going into cytokine release storm, someone with high interleukin-6 inhibitor, and very few labs in Kuwait can conduct this test. And also if you have someone with high ferritin or high CRP or high LDH with high D-dimer, you can administer tocilizumab 8 milligram per kg, and you might repeat the dose after 24 to 48 hours. If you don't have tocilizumab, you have the option of using anakinra as per MOH protocol. However, we will notice now when we review the international guidelines, this recommendation hasn't been adopted by any of the current guidelines. So the NIH recommends tocilizumab for two categories: someone within 24 hours of ICU admission who require invasive or non-invasive mechanical ventilation or high flow oxygen.
Dr. Almander, sorry, but you have 5 minutes left, okay?
Okay. Or someone recently hospitalized with rapid deterioration with high inflammatory marker. So IDSA guideline, in summary, they only recommend steroid. Also, they suggest using tocilizumab for severe, progressive, or critical cases. Also, they suggest using remdesivir, someone with severe COVID, and they recommend using the monoclonal antibodies, the bamlanivimab and the atezolizumab for ambulatory surface. They are against the use of most of the current therapeutics, the old therapeutics like that we mentioned earlier. And also they are against the use of bamlanivimab alone because of the ongoing mutation on the virus, which made the new viral strain resistant to this monoclonal antibody. NIH has almost same or less the same recommendation. They recommend for the ambulatory service to use bamlanivimab plus atezolizumab. And also for hospitalized patients who require oxygen, you have the option to use remdesivir or remdesivir plus dexamethasone. And if you cannot use steroid, you have the option to use the paracetamol. And we have very, very limited or very few patients who are really have contraindication for steroid. WHO has a very simple guideline. They categorize disease now into non-severe, severe, and critical. And the only drug that is recommended by WHO is the corticosteroid for severe cases. And they recommend to use prophylaxis anticoagulant. They are against the use of all other therapeutics, including the immunomodulators that we mentioned earlier. Also, they are against the use of remdesivir because the study shows no benefit of this antiviral drug. What about ivermectin? A lot of talk nowadays about this antibiotic drug, which has been for a long time for many parasitic diseases like scabies, onchocercosis, and strongyloides. However, no evidence, and there's insufficient data. I know they changed their recommendation from against to a better level, which is insufficient data to recommend with or against ivermectin. However, we cannot recommend this drug. We already mentioned that monoclonal antibodies has a role only in ambulatory, so you might use it for someone in the outpatient setting, and none of these drugs is available in Kuwait. However, we might get soon the GSK 7831, which is a full monoclonal antibodies. It's a very promising drug. Still, the data is not published, but from the press release, it can reduce the hospitalization and mortality by 85%. it is against, it works well against the new viral strains. In general, for monoclonal antibodies, it should be administered IV early, within 5 to 10 days of symptom onset, and only for high-risk group, because it has its own serious side effects, and also it is a very costly drugs. So I think I'll stop here. Thank you for the presentation, and sorry for the connection errors.
Thank you very much, Dr. Al-Munder. I received a question. What are the most common causes of mortality in post-COVID infections, i.e. those who recovered initially from corona infections? Is it P or is it arrhythmias?
Yeah, the most, we are conducting now a recovery clinic in Jabal Hospital, which is the medicine of COVID in Kuwait. And the most common presentation after recovery is the thromboembolic event, which might manifest as PE. Also, some patients might present with cardiac vascular disease. So I believe this is the most common cause of mortality in recovered cases.
Tamam. There's another question, Dr. Munder.
Yes.
When does the immunity starts, and how long the immunity lasts for different types of vaccines?
Yeah, the immunity, it really depends on the type of vaccine, but in general, the maximum immunity happens after the second or the full, when you complete the full authorized doses of the vaccine. So if you have a single dose vaccine like Johnson & Johnson, or if you have a 2 doses vaccine like Moderna or Oxford or Pfizer, it happens 2 weeks after the second dose. And when the CDC advised that people who are fully vaccinated, they can escape the post-exposure quarantine, it means that within 2 weeks of the last dose and 3 months after the last dose. So this is the maximum period of immunity. After the 3 months, we still don't have enough data. Recently, a new paper published that the immunity might last very well, more than 90% at 6 months. And we are waiting for more data to support this suggestion.
Okay, one last question. In diabetes with the GFR less than 60 but more than 30, do you advise immunization? And what about patients? Okay. Question.
Yeah.
In diabetic patients with GFR less than 60 but more than 30, do you advise immunization? And
yes.
What about patients with IgN and on immune suppression? Do you advise vaccination?
Yeah. Yes. So this is a very important thing, really, to know that the vaccine, the low immunity wouldn't affect the vaccine safety. When we talk about immunocompromised or people who are in immune suppression, the issue is not about safety, it's about the immunogenicity, the ability of the body to produce antibodies. So whenever you have an immunocompromised patient and you feel that there's no chance to hold or postpone his immunosuppression dose if he's on medication, it's better to get the vaccine as soon as possible. Getting partial immunity is better than no immunity. And for the other question, for the low EGFR, it's not one of the current contraindication of the vaccines, neither the Oxford or Pfizer.
Okay. Thank you very much, Dr. Al-Munder, for your very informative lecture. I have 2 notices that now we come to the end of our official lectures for day 1. And tomorrow, inshallah, we'll start the lectures at 5:45 p.m. So I'll see you tomorrow. Thank you all.
Thank you.
Miss
Thank you.
Rana Atif, are you here?
Yes. Yes, I'm here.
Yeah. Can you on your video and start introduction?
Yes. Okay. Sure. Yes. Okay. So good evening, doctors. Thank you all for your attendance today. This is Rana Atif, Medical Science Liaison, responsible for Metabolism Therapeutic Area from the Medical Department, Boehringer Ingelheim. So please let me introduce Dr. Bassam Abulbanat, our eminent speaker for tonight. Dr. Bassam is a consultant cardiologist at Sabah Al Ahmed Cardiac Center, Al Amiri Hospital. Now, Dr. Bassam, the floor is yours.
Thank you very much, Rana. I'd like to thank Boehringer for basically inviting me to be a speaker today with you. For the ones who attended the first lecture, so this is basically a different sort of a, if you'd like to say, a platform. So we are basically, we are going to be talking about predominantly heart failure with regard to diabetes. So I'm going to only talk about heart failure with regard to diabetes. Rana, you are seeing my slides? Just I want to make sure. Oops, what happened?
Yes.
Okay, just a second. Something happened. Just oops. Okay, you are seeing me now?
Yes, but not in full screen. Yes, now in full screen.
Okay, good. So basically, the way that I'm gonna go through the lecture, I don't know if you've heard about the causal inference law. This basically it's something similar to the Koch's postulate, which basically put the basics of causality for infections. So you have to have an organism which causes a disease. Then you have to take off that organism to prove that there's no disease. And if you treat that organism, you're going to have to treat the disease. So it's sort of in that direction. So basically, we know that the rates of all-cause and cardiovascular mortality basically have been declining over the past decades for both diabetics and non-diabetics. But definitely for those diabetic patients, despite that the all-cause mortality and death from cardiovascular disease declining, but the rates are still considered to be high to the rest of the literature, to the basically the rest of the population. And now, if you remember, there is a basically a slide which I think I showed in the previous lecture with regard to the MI and diabetes mellitus. This is the Taiwan National Health Insurance Registry, and it shows you for diabetes and heart failure something similar. So if you have if you are a non-diabetic without with any heart disease, your risk is going to be basically high for heart failure development. And if you are diabetic without heart disease, your risk is similar to somebody as if he had a basically heart failure. So the same equation which applies for myocardial infarction applies for heart failure in patients with diabetes. So the risk of heart failure in people with type 2 diabetes and no established cardiovascular disease is similar to controls with established cardiovascular disease. And this is an important thing for you to understand. And when you look basically as the different risk factors that we have with regard to diabetes and heart failure, still diabetes is considered to be the most important determinant of development of heart failure compared to other risk factors, be it in African Americans or in Caucasians. This relationship stands true in the Gulf area. For the ones who attended my first lecture, this is basically the Gulf Care Registry. The upper line represents the age, the red line represents the diabetes, and the first squares of each of those represent the Gulf registries. So in the Gulf registry, patients who are admitted with acute heart failure to the hospitals, they are younger than the basically balanced European patients by a decade. Moreover, 50% of those patients, they have type 2 diabetes mellitus. When it comes to the mortality, 12-month mortality, They are similar to the European registries, but we said that our patients are younger. So they are younger, but they are having similar mortalities to the European registries, which means this is a worst case scenario because they are younger and they have similar mortality to older patients, if you'd like to say. Let's now shift to deciphering the data in heart failure and cardiovascular death with type 2 diabetes mellitus drugs. Once you develop heart failure, believe it or not, your 5-year mortality is 50%. That's almost similar to a lot of the worst case scenarios that of cancers that you are aware of. For example, pancreatic CA. This is a very important slide. I like it. I borrowed it from Dr. Shilton, basically. It shows you the complexity of heart failure and its relation to diabetes mellitus. You have here 2 patients. The one on your left hand of the screen is a patient who was admitted with pulmonary edema, and he has cardiomegaly with a poor ejection fraction of 35%. The one on the right-hand side has as well pulmonary edema, but has a small heart and has a normal ejection fraction. Both of those patients have ischemic heart disease. Actually, in the clinical trials, we do not know which patient we are dealing with, but when they talk about those patients, both patients have the same basically endpoint. And this is very clearly seen in the autopsy of those patients. So basically, you have here a diabetic patient with ischemic heart disease who has a scar here because of a myocardial infarction and dilated heart who passed away. On the other hand, you have here a patient with a normal ejection fraction, thick heart with diastolic dysfunction who passed away as well. So really, once you develop heart failure, it's a bad thing. Let's shift now to the bottom line of our talk. So the way that I want to run this talk is going to be to establish the causal inference based on the Bradford criteria. So we're going to be talking about consistency, specificity, temporality, biological gradient, and finally experiment, which are the RCTs, with regard to the relation of diabetes mellitus and heart failure. So let's start our journey. The first pillar is to establish the consistency, specificity, and temporality between diabetes and congestive cardiac failure. This relationship has been established back in 2000, and this slide clearly shows you the association between hemoglobin A1C and heart failure in the UK PDS trial. So it's very clear, as your hemoglobin A1C grows up, your basically incidence per 1,000 patients years with heart failure goes up. So it's very clear association. It's not only that, even in patients, that's basically seen in the paradigm heart failure trial, even in patients with pre-diabetes, those patients compared to patients with normal hemoglobin A1C, they have a higher risk of cardiovascular death or hospitalization for heart failure compared to normals. Albeit, of course, diabetic patients, they have the highest basically prevalence of cardiovascular death or heart failure hospitalization. Now this, if you'd like to say relationship of consistency, it does have some heterogeneity within it. By heterogeneity, we mean that this relationship seems to be more stronger in females. So once you have diabetes mellitus, this will increase the risk of heart failure development by 2-fold in men and by 5-folds in men. If you recall my first lecture in the COVID, the same relationship in the Gulf area was clear, is that ladies who had ACS, they had more chance of having diabetes mellitus, 55% compared to 40 in males. So this relationship stands true. And this relationship has been found basically with regard that the ladies being at highest risk with excess risk of heart failure in diabetic patients across whatever registries you like. So basically this relationship is robust. It's not by chance. So that was our first pillar. So the first pillar, we have approved the consistency and specificity. The second pillar was to prove the biological gradient. By biological gradient, meaning it's a dose-dependent relationship. Heart failure is the most common cause of cardiovascular hospitalizations among patients with diabetes mellitus with regard to the other cardiovascular illnesses, be it acute coronary syndrome, cardiac dysrhythmia, ischemic stroke, hemorrhagic stroke. So heart failure is still the commonest cardiovascular endpoint, either if you are talking for men or women. So this is basically the commonest thing that we're gonna face in clinical practice. The other thing is that heart failure, despite being the commonest one, as well as it represents the most unfavorable prognosis in patients with type 2 diabetes mellitus. So it is the most frequent, as well as it is the most unfavorable prognosis in patients with type 2 diabetes mellitus. This is the 5-year absolute risk of death. If you're gonna see here that patients with heart failure, they have the highest chance of having 5 years chance of dying compared to the rest of the cardiovascular diseases. And this is again shows you the other now, if you'd like to say, level. So we said that patients with diabetes, they have more chance of having heart failure. Not only that, if you have now diabetes and heart failure, it becomes like a double whammy. Like we said, that COVID and diabetes. So diabetes and heart failure, your mortality rate becomes much more higher. It's a multiplicative. So if you don't have diabetes and heart failure, your risk of dying is here. And if you have diabetes, your risk of dying goes up significantly. And this relationship has been found quite significantly in other trials, like the LIFE and the renal trials. So in the LIFE, basically we have 2 lines, the red representing basically patients with heart failure, and the blue without heart failure. So if you have diabetes and heart failure, see what happens to your basically cumulative event rate. It's not additive, it's multiplicative. Like see here, it goes up from 0.1 almost to 0.4. 4 times, 4-fold increase in that risk. So that was heart failure in general. What if we looked at heart failure in the 2 common forms, which are the heart failure with a reduced ejection fraction and heart failure with a preserved ejection fraction? Let's start with heart failure with a reduced ejection fraction. The same correlation stands true. So diabetes is prevalent amongst people with heart failure with reduced ejection fraction, and most, like those are all of the registries. It's anywhere between 20 and 40%. Remember, in the Gulf care, we were what? 50%. So still, the Gulf, we are having the highest level of heart failure in diabetics compared to the rest of the globe. And this is important because it means whatever intervention you're gonna have in the Gulf is gonna give you the better outcome amongst the rest of the world. Now, this is another level of association. This is basically, this study, what they looked at is that patients with diabetes, what was the percentage of them having poor LV systolic function? So you have the red line, the red bars are patients with diabetes, white patients without diabetes. So what is your chance of having a poor LV systolic function here? It shows you clearly if you are diabetic, you're gonna have a much higher chance of having a poor LV systolic function, less than 30%. When it comes to a normal LV systolic function, if you have diabetes, you have a much lower chance of having a normal LV systolic function. The second level of association is this, is that patients with asymptomatic LV systolic dysfunction are evident in the absence of overt cardiac disease 5 years after the type 2 diabetes mellitus. So what I showed you, the previous slide, the figures, is that after the diagnosis of type 2 diabetes mellitus by 5 years, basically you're going to see some sort of LV systolic dysfunction, even if it's asymptomatic, in quite a percentage of patients. So 68% of people with type 2 diabetes mellitus, they had evidence of LV systolic dysfunction, any form, diastolic, systolic and diastolic, by 5 years after the diabetes diagnosis. And the incident heart failure occurs earlier in patients with type 2 diabetes mellitus with asymptomatic LV systolic dysfunction. That is why it is important to diagnose LV systolic dysfunction in diabetics, even if it is asymptomatic. Why? Because this is a prerequisite for the development of incident heart failure later on. And that was very clearly shown in the SOLVE trial. So basically, again, this slide shows you patients with diabetes and without diabetes. If you have diabetes with asymptomatic LV systolic dysfunction, you have a higher chance of developing heart failure. Moreover, you're going to have a higher chance of developing heart failure or cardiovascular death. So that's why it's an important thing to look for. And I showed you this slide in another way. That's the paradigm. So even patients with pre-diabetes, they are at an increased risk of heart failure, hospitalization, cardiovascular mortality across the ejection fraction spectrum. So that's basically ejection fraction less than 15, 15 to 20, up to more than 35. However you're going to look at it, even if you have pre-diabetes, you are at a higher risk of having cardiovascular mortality or heart failure hospitalization. However you're going to look at the ejection fraction. You might say, well, that's because it's patients, they have reduced ejection fraction. You might think that this biological gradient is not there in patients with HFpEF. That's not true. Basically, this is a slide which shows you the most famous trials in HFpEF: CHARM preserved, I preserved, TOPCAT, Paragon, heart failure. This slide shows you clearly that diabetes is prevalent amongst patients with heart failure with a preserved ejection fraction. Those percentages going anywhere between 28 to 43%. So the same relation applies. What about the other way around? Is diabetes associated with higher mortality in patients with HFpEF? Yes, that's basically from the I preserve. That's the all-cause mortality. If you have diabetes with heart failure with preserved ejection fraction, you have a higher chance of dying if you don't have diabetes. And that's again associated with higher BNP values, more LVH, and more diastolic dysfunction in this population. So what we have proven until now, we have proven in the causality, we have proven the temporality, the consistency, the specificity, and the biological gradient. What is missing by now is basically the experiment, the RCTs, to show you that if you treated diabetes, that's going to translate into lowering your heart failure mortality. And I'm putting decades of samples, despite knowing all of this data, which goes back from the year 2000, almost a decade and a half, we had nothing with regard to improving the mortality when it comes to decrease by treating the diabetes. Actually, with the micro complications, with the microvascular complications, we were way ahead of that. We knew as far as the year 2000, 21 years ago, that if you lower hemoglobin A1C, you would reduce the risk of microvascular complications in the form of renal and retinopathy. But we had nothing when it comes to basically cardiovascular outcomes. Those are most of the famous basically trials with regard to the more intensive glycemic control, and we have shown modest effect on atherosclerotic cardiovascular disease and none whatsoever on heart failure outcomes. Not only that, actually we had the FDA guidance trials, if you remember the TZDs, which are the rosiglitazone and pioglitazone, they had higher impact on heart failure by causing more heart failure. They were causing more harm. And then we had the post-PDA guidance, which came then the DPPs, GLPs, and the SGL2s. This is basically a summary of most of the 4 DPP inhibitors that we know about, which are the saxagliptin, alogliptin, and sitagliptin, and linagliptin. The bottom line is that the DPPCs are neutral with regard to heart failure hospitalization. This was an important step because people were worried, remember, from positron, that people were worried that those new medications could lead to higher hospitalization with heart failure. So the fact that they were neutral, that was a good sign. Of course, except for examine, which was alogliptin, there was a trend maybe of more heart failure hospitalization. Apart from the rest, they were neutral. Then came the GLPs with regard to the cardiovascular outcomes. So the GLTs, they have shown basically a reduction in MACE as well as heart failure hospitalization, but that was driven predominantly by the MACE rather than the heart failure hospitalization. Then we had the year 2015. That is the year of the final pillar, which I call it. That is the year that we have proven by experiment that if you have a medication which is gonna treat diabetes, this medication through other mechanisms can decrease heart failure hospitalization. And that started with empagliflozin, with the EMPERIG trial. So in this trial, clearly empagliflozin significantly reduced the relative risk of heart failure hospitalization by 35% on top of standard therapy. And this benefit was very early. Actually, there was an early separation of the curves for heart failure hospitalization. You don't see that even with our best medications. You don't see it with Entresto, you don't see it with ACE, you don't see it with beta blockers. Probably this is the best medication that shows you early separation between the curves that we have. And that was a hint for a lot of the basically principal investigators that those medications would probably, as you're gonna see, turn into heart failure medications. Those benefits were basically valid for the empagliflozin at the 10 as well as the 25 milligram doses. The same thing happened with the canvas, basically the canagliflozin. Again, we had a 37% relative risk reduction in heart failure hospitalization. And again, the same thing happened with DECLARE. We had a 27% relative risk reduction with regard to the heart failure hospitalization, be it in the primary or in the secondary group. So when it comes to heart failure hospitalization, all of the SGLT2s which are available to us, they have reduced heart failure hospitalization. And if you're gonna look at the different trials, I'd like you to basically, when you look at those trials, you have to understand what they were looking for. And that's important because that's when you're gonna be using those medications in clinical practice. So you have to understand your patient is fitting which medication, which molecule, so that he can use it in the right way. In the EMPERIG trial, this was basically a primarily secondary prevention trial. So all of the patients, they had established atherosclerotic cardiovascular disease, which is my specialty. I'm a cardiologist, so I'm gonna see a lot of those patients in the hospital because my patients are coming with MI, ACS, so they have an established atherosclerotic cardiovascular disease. When it comes to the canvas, it was a mixture, 66%, 2/3 were secondary, 1/3 primary. For DECLARE, it was predominantly 60% the other way. It was 60% primary prevention and 40% secondary prevention. And those are the GFRs which were tested in the trials. When we look at the meta-analysis of the cardiovascular outcomes for the cardiovascular death or heart failure hospitalization by the presence of atherosclerotic cardiovascular disease, it was very clear that if you have atherosclerotic cardiovascular disease, you're gonna have a much better reduction in the basically cardiovascular death / heart failure hospitalization. Yes, still if you have only multiple risk factors, that's primary prevention, you're gonna have a benefit, but it's not like if you have it for secondary prevention. And if you're gonna look basically at those differences, you're gonna see that patients with heart failure, with previous history of heart failure, with no history of heart failure, they all benefited. So this benefit was regardless of the having a history of heart failure. Of course, if you have heart failure, the benefit was more, but this benefit was regardless. And this was clearly, it was more seen with basically with the MPERG. So we're gonna see that all of the three molecules, if you have a history of heart failure, the three of them, they reduced heart failure hospitalization. When it comes to the MPERG, it was outstanding in the form, even if you don't have history of heart failure, you're gonna have benefit with regard to this outcome. I'm gonna skip the EGFR, and then I'm gonna come to the final slides. This is what I call the final nail in the coffin. So what we have proven until now is that we have already achieved all of the requisites for the Bradford causality inference criteria. Then came this. So then after the MPERG, then we had basically the Emperor trial, which looked at the following. The Emperor reduced trial specified only 3 endpoints to be tested in the hierarchical manner. So they looked at the composite of cardiovascular death or heart failure hospitalization. The secondary endpoint was total, first, and recurrent heart failure hospitalization. The secondary endpoint was a slope of decline in glomerular filtration rate. Because my talk is about heart failure hospitalization, we're going to be talking mainly about heart failure. Those are the patient depositions. So we're talking about 7,200 patients, and they ended up randomizing 1,800, 600 in each arm with the IMPA, and the second arm with the placebo. And what they have found in the Emperor reduced is that the time to the cardiovascular death or hospitalization for heart failure was basically significantly reduced, and that was independent of having diabetes or not having diabetes. And again, what I want you to notice here is that the curves separated very early, and that's a unique thing for almost all of the SGLT2s when it comes to that. When we're going to look at the effect on the individual components of the primary endpoint, when it comes to the MPERG, again, we had a 25% reduction of the primary composite outcome, a 31% reduction of first hospitalization for heart failure, and an 8% reduction of cardiovascular death. Of course, this was the p-value here is not given. And when it comes to the primary endpoints and the subgroup analysis, this is one of the important things that the Emperor gave us on top of what the Emperor gave us, is that those benefits were seen even in patients with diabetes and non-diabetes. That is why the Emperor trial set the platform for making SGLT2s probably, and this molecule specifically, a molecule that could be used in heart failure management, regardless of having diabetes or no. And that's an important message for you. Those are all of the primary endpoint subgroups. So whatever you're gonna look for the overall heart failure hospitalization within 12 months, etiology of heart failure, baseline NYHA class, nature of heart failure physiology, all of those were in favor of basically the MPERG. When it comes to the total hospitalization for heart failure being the first and recurrent, that's the second hierarchical endpoint. Again, there was a clear 30% reduction with the MPERG. Again, what I want you to notice, see how early the curves separate. The reason I'm giving you that is that I want you to develop this art is that to look at the curves in a good way. And when you look at the reductions in the risk of heart failure hospitalization or cardiovascular death, this was consistent across subgroups by baseline hemoglobin A1C. What we mean is that the heart failure hospitalization and reduction in cardiovascular death was sort of independent of basically hemoglobin A1C. So this is an indirect evidence that's suggesting that non-diabetic patients with heart failure may benefit from empagliflozin. I'm of course saying this is a post hoc analysis. This is actually a recent thing that we are trying to pay attention for. So that's why the importance of the emperor is coming, because it's putting the platform for using SGLT2s in heart failure population. So the emperor achieved all the three hierarchy specified endpoints at significant p-values. It reduced the composite of cardiovascular death or heart failure hospitalization. It reduced the total first and recurrent heart failure hospitalization. And again, for our renal colleagues, it reduced the slope of decline in glomerular filtration rate over time. And this is, of course, well known before. That's for even it was known with the EMPERIG trial. What about the all-cause mortality? There was a trend towards lower mortality in the empagliflozin, but the p-value is not significant. So we can say it is a neutral here. And this slide shows you that empagliflozin, if used in basically acutely in patients with acute heart failure, it is a safe and well-tolerated medication, even if it is started in the hospital. So basically, that shows you what's going to happen to the patient. So the worsening heart failure, death or heart failure readmission, death or heart failure readmission at 60 days, worsening heart failure or heart failure readmission at 60 days, worsening heart failure, death or heart failure readmission at 60 days. All of them show you a superiority with empagliflozin. And those are the side effects that we are having. So basically, the cardiovascular, we have shown that EMPERIG is superior, and the rest of the side effects were not basically different between the two. Now, the last few slides, I'm going to show you the comparison between the two dedicated basically trials which have been tested, SGL2 trials to test for basically heart failure. We have the EMPEROR reduced, which we have shown you, and the DAPA heart failure. So the EMPEROR reduced, they were for adults with ejection fraction less than 40, with and without diabetes. DAPA, again, adults with ejection fraction less than 40, with and without diabetes, same. The NYHA class in the DAPA was 2 to 4, NYHA class 2 to 4. Both of them elevated pro-BNP. Systolic blood pressure in the DAPA was a bit lower by 5, more than 100. And the eGFR in the DAPA, which was tested, was 30. EMPEROR, they tested a lower GFR, so you can use it even, they tested even more advanced renal impairment. And that's important for us to understand. What about the patients population? The mean ejection fraction in the EMPEROR was 27, DAPA 31, so we had lower ejection fraction. The NYHA class, though they were about 75, here is 67. Now, what I want you to understand, this is not a head-to-head comparison, and I hope that you all understand this thing. What we are showing you, the patient population of each of those trials, it means nothing. It's not a comparison, it's not a randomized comparison. It's just a comparison for us to look at them. Usually when I show those NYHA class symptoms and the ejection fraction, I give a teaching point. The teaching is that as follows. You probably think that always, for basically in medicine and even in non-medicine doctors, they think if you have a ejection fraction is 25, you should always feel like, you should be NYHA class 4. No, that's not true. Actually, look at basically the mean ejection fraction in the EMPEROR, 27, less than DAPA. But the percentage of patients who were basically in the NYHA class 3 were higher in the DAPA than the Emperor. Again, this is not a head-to-head comparison. It's just to look at the two characteristics. Those are the median BNPs were higher in the Emperor compared to the DAPA. Mean EGFR 61 lower because they included lower GFRs from 20. The event rate in the EMPA was about 15.8, here 11.8, and the PBO was 21 and 15.6. This is again to show you the difference between the two with regard to the numbers. So basically 25% reduction in the cardiovascular death or heart failure hospitalization. First hospitalization for heart failure, almost the same. Renal composite endpoint, 50, 71, and cardiovascular death in the DAPA was 82 compared to 92. Again, those are not head-to-head comparisons. This is the first hospitalization for heart failure. What you're going to see is that Emperor, because they were looking into that, we had a higher decrease in that. And cardiovascular death in patients with a prior myocardial infarction, you're going to see that clearly here. With the Emperor, if you have a previous myocardial infarction, then you're going to have a significant reduction in cardiovascular death in patients with prior MI. Again, those are not to compare. This is not to mean, this is not meant to compare both the trials. It's actually just to look at each trial and see where your patient might fit. Again, this is basically the HFrEF outcome trial, so the primary endpoint, so that's basically the DAPA. You can see very clearly that both of medications, early separation, that's the message that we are having with regard to the endpoints when it comes to cardiovascular death or heart failure hospitalization. This is the NADS meta-analysis. This is a famous meta-analysis that basically included both the trials. So those are the two important trials with the SGLTs with regard to the heart failure population in patients with and without type 2 diabetes. What they have found is that both medications, they reduced heart failure hospitalization, cardiovascular death by almost similar percentages. So again, this tells you that the overall HR for both medications was about 26% reduction in the risk of heart failure hospitalization. So now let's look at where SGLT2s stand in the basically diabetes treatment. Now we know that for patients with type 2 diabetes mellitus, those are the different medications that we have. So let's look at what we have with regard to decreased cardiovascular events. Basically, we have leader and sustain, but SGLT2s, they stand up. When it comes to the micro complications, you have a lot of the evidence there. Lipids, statins, PCSK9, hypertension, you have the AT1 receptor blockages. When it comes to which molecule fills all of the required criteria, look at the SGLT2s. You have decreased cardiovascular events, decreased cardiovascular death, reduction in heart failure hospitalization. And if you compare them, they are at the same line as paradigm statins. So this is a gold. That's why we put for you the rectangle in a gold. So this is basically a medication. This group of medications, they're gonna be heart failure medication, and no question about that. This slide shows you the SGLT2 inhibition and the cardiorenal protection, and those benefits are independent of hemoglobin A1C, deep blood pressure reduction, weight reduction, EGFR. So it basically shows you the potential benefits of SGLT2 being at the endothelial level and at the basically hormonal level, if you'd like to say. This is, I'm gonna end up with this basically article. This is a very famous, this is an editorial which was written by Dr. Cosentino. He's a famous guy. And because of the basically what we have seen we're going to show you that. So that's the guidelines in 2019, because what I've showed you with the empiric, see where are the SGLT2s are coming. They are coming very high in the choice for patients with either diabetes, pre-diabetes, cardiovascular disease. So there are class 1 indications for those. And MPEG-LIF is recommended in patients with type 2 diabetes mellitus and cardiovascular disease to reduce the risk of death, because it was the only one that showed that. This is basically the article that I was talking to you about. This is written by Giuseppe Rosano. He's one of the basically eminent leaders in this field, and he's anticipating where the SGLT2s are gonna come in the heart failure literature, not in the diabetes literature. So basically, based on the DAPA-HF and the Emperor reduced trial results, he's anticipating that SGLT2s probably will be added along the, if you'd like to say, the spectrum of heart failure medications. So he's expecting ACE beta blockers are going to be class, and those are going to be first. And then you can introduce SGLT2 anytime after that. So probably you're going to add an MR antagonist, and probably you'll be able to add SGLT2s anywhere within those lines. But still, this is not a guideline. This is an anticipation of Dr. Giuseppe Rosano of what's going to happen. So with that, I'm going to come with the basically conclusion of my talk. So I'm going to leave you with this last thought. Do you think that the mission is complete, or is it? Thank you very much. And I'm open for questions. And the floor is yours.
Thank you so much, Dr. Bassam. Thank you so much for the very informative presentation, but I believe our time is finished. So thank you so much, and great evening. Thank you.
Thank you.
Hello, everybody.
Hello, Professor Glenn.
Hi there, how are you?
I'm fine. How are you, Doctor?
I'm very good, thank you.
So we have Professor Glenn Metfin over here. He is a professor of medicine, MBRU College of Medicine, Dubai, UAE, consultant endocrinologist, medical clinic, Middle East, Dubai, UAE. So Professor Glenn is going to present his talks. So can you start, Professor?
Sure, no problem. So these are my disclaimers. As you are aware, this is